Can you hear me?
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Sir, actually, hello, adjustments. No, sir, we actually slide. Actually, it's on slides here, no? That's right.
Can you hear me?
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually, hello, adjustments. No, sir, we actually slide. Actually, it's on slides here, no? That's right.
Can you hear me?
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually, hello, adjustments. No, sir, we actually slide. Actually, it's on slides here, no? That's right.
So do we have Dr. Tejas? Yes, sir. Hi, good morning.
Good morning. I'm here.
Yeah. Sir, you are now in Rajkot, right, sir?
Yes, I'm in Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually, hello, adjustments. No, sir, we actually slide. Actually, it's on slides here, no? That's right.
So do we have Dr. Tejas? Yes, sir. Hi, good morning.
Good morning. I'm here.
Yeah. Sir, you are now in Rajkot, right, sir?
Yes, I'm in Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually, hello, adjustments. No, sir, we actually slide. Actually, it's on slides here, no? That's right.
So do we have Dr. Tejas? Yes, sir. Hi, good morning.
Good morning. I'm here.
Yeah. Sir, you are now in Rajkot, right, sir?
Yes, I'm in Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually,
Getting a loop of recordings regularly.
sir, we actually
Same recording is in loop.
That's right.
So do we have Dr. Tejas? Yes, sir. Hi, good morning. The same audio is repeatedly playing.
Yes, sir. Let me check.
The same
Yes, sir.
that audio is repeatedly
I'm in
playing.
Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually,
Getting a loop of recordings regularly.
sir, we actually
Same recording is in loop.
That's right.
So do we have Dr. Tejas? Yes, sir. Hi, good morning. The same audio is repeatedly playing.
Yes, sir. Let me check.
The same
Yes, sir.
that
Let
audio
me
is
check.
repeatedly
I'm in
playing.
Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually,
Getting a loop of recordings regularly.
sir, we actually
Same recording is in loop.
That's right.
So do we have Dr. Tejas? Yes, sir. Hi, good morning. The same audio is repeatedly playing.
Yes, sir. Let me check.
The same audio is repeatedly
I'm in
playing.
Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually,
Getting a loop of recordings regularly.
sir, we actually
Same recording is in loop.
That's right.
So do we have Dr. Tejas? Yes, sir. Hi, good morning. The same audio is repeatedly playing.
Yes, sir. Let me check.
The same audio is repeatedly
I'm in
playing.
Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually,
Getting a loop of recordings regularly.
sir, we actually
Same recording is in loop.
That's right.
So do we have Dr. Tejas? Are you there? Hi, good morning.
Yes, sir, I'm joining
What happened? Why there is a disturbance? There is a repeated audio coming.
Yes, sir. I'm checking with tech team. Just a minute, sir.
Audio is repeatedly
I'm in
playing.
Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually,
Getting a loop of recordings regularly.
sir, we actually
Same recording is in loop.
That's right.
So do we have Dr. Tejas? Are you there? Hi, good morning.
Yes, sir, I'm joining
What happened? Why there is a disturbance? There is a repeated audio coming.
Yes, sir. I'm checking with tech team. Just a minute, sir.
Audio is repeatedly
I'm in
playing.
Rajkot.
Yes, sir, we can hear you.
I can't start my video because host has stopped it.
Just a minute, sir. Actually,
Getting a loop of
Avinash, bolo.
regularly.
sir, we actually
Same recording is in loop.
Hello. Venkat sir, please check now. I think it's fine. Sir, please unmute. Sir, please unmute.
Yeah, we are at 59. We'll start sharp
Yes.
at 60.
You can start.
Should we go?
Yes, sir.
Yeah, good morning, friends. Welcome to the new normal. A fantastic day of virtual conference already
happened yesterday. So we invite you the second day to the CHARAKA Hall. And we have some fantastic speakers and some fabulous talks today. To start the ball rolling, I now invite Dr. Tejas Motivaras, who is actually a chief intensivist and also director of Gokul Hospitals. He is from Dr. Rajkot. So I invite Dr. Tejas to take over. Dr. Tejas.
Thank you, Dr. Venkatraman. So what a day ahead. Today we'll be having in this CHARAKA Hall the best of the best lectures which defines this virtual conference. And that's from none other than the stalwarts and the founder members from the critical care in India, those who has defined critical care in India. And we begin with our opening session from Dr. Babu Abraham, who will be talking about the ventilator-induced lung injury. Dr. Babu Abraham is a consultant intensivist and director at Apollo Hospitals, Chennai. He did his medicine training from United Kingdom and his fellowship in critical care from Toronto, University of Toronto, Canada. At present, he is working as teacher, recognized teacher, and an examiner for DNB, IDCCM, and IFCCM. He is author to many journals author to many publications in reputed journals. So, ladies and gentlemen, let's hear from the stalwart himself, Dr. Babu Abraham.
Good morning, everyone. My name is Dr. Babu Abraham, and I will be talking to you today on micromechanics causing villi. I will be spending next 30 minutes running through an introduction which consists of 2 slides going through the history of our understanding of microvilli, another slide on certain definitions of terminologies that we use, about 10 slides on mechanical energies and its components, and then a few on mechanical power. I'll have about 8 slides on micromechanics and villi, and then I will conclude and we should be over in next 30 minutes. So to move on with it, our understanding of villi has improved over the last 2 decades. Initially, we understood that high tidal volumes was a problem. Then we thought that it is the high plateau pressure, the combination of 2. Then we moved on to using high PEEP and the open lung approach. Then we realized that a driving pressure could be the problem, and we went to a low driving pressure. Then we moved on to the ventilating power and using low ventilating power, stress and strain. And then we went on to driving power. And of late, over the last few years, our main focus has been to reduce cumulative injurious strain. But what we know for sure is none of these interventions on its own cause villi, and energy and power applied to lung parenchyma is the root cause for villi. Let's look at certain terminologies that we are using. Now, stress and strain is very common terminology we use. I'm not going to go explaining what it is, but energy. What is energy? When we look at it, it's nothing but work done. Pressure into volume change is work done, and the ability to do work is called energy, and the unit for energy is joules. What is power? Power is nothing but energy expended per unit time. So it's a product of inflation energy and ventilating frequency, and you see the unit used is joules per second or joules per minute, depending on the time unit used. I would like to bring in the new concept of specific power, which is nothing but power divided by volume, which looks at the power which is applied to unit tissue. We'll be talking about it more. A new concept of threshold. which tells us stress and strain level at which the tidal damage is initiated. We'll be explaining that. And cumulative energy load and cumulative strain is nothing but total number of energy or strain cycles delivered over a given period. And that is what we think is the main cause for villi. The concept of unaccounted or observed energy, we think this could be the cause for micromechanic changes that happens within the lung. Let's move on and see what the micromechanics are. We need to understand that energy which is produced cannot be created or destroyed. It can be expended. It can be converted from one form to another. And with that, we'll move on. Now, let's look at the energy that is produced when a ventilator delivers a breath. All of us are very comfortable with this pressure time scalar. It is a constant flow scalar in which the time is analogous with the volume. Now, if you look at it, this is divided into three parts. The part A is where the energy is mainly from the flow resistive. Part B is called the tidal elastic energy, and C, which is mainly the total PEEP, which is called the PEEP related energy. We will go through each of this separately. This whole portion of the pressure time scalar is the work which is done. Now, what we need to know is mechanical work done with passive tidal inflation is mainly done to move the whole respiratory system, which is the lung and the chest wall. Now, let's look at each component of the energy. The flow resistive energy, which is shaded as A, it's mainly a kinetic energy. It pushes gas through the alveoli and deforms tissue. So the frictional losses that you see are from the movement of the airway epithelium and movement of tissue within the lung parenchyma. And that is because of what is called the viscoelastic drag. We'll talk more about it. Now, what is seen is if you deliver the energy at a faster flow rate, higher would be the energy expended, and this is due to the viscoelastic drag. It is converted into heat and it is not stored. So all of the flow restrictive energy is converted into heat. The second part of the energy, the tidal energy, is the tidal elastic or dynamic energy. That is also a kinetic energy, and like the previous, the flow restrictive energy, it is converted into heat. It is used to move the lung tissues, and it forms, along with the flow restrictive energy, forms the major chunk of what we call the tidal inflation energy. Now, if you look at it, this is the part that the driving pressure usually comes in. So it relates to the driving pressure, and the energy loss depends on the lung compliance and the tidal volume delivered. Its effects are concentrated by the low capacity for the baby lung, and we think this is a major component for injury to the baby lung. We will discuss more about this. And we think that it could be the central cause for villi, and this is a big debate that still goes on, and we'll touch upon this too. Now, what needs to be understood is part of this energy is stored during the transition from P to the plateau pressure, and that stored energy is then used during the expiratory phase. Now, the third component of energy is the PEEP related energy, or the static elastic energy. It is a potential energy, and traditionally it does not take part in work of breathing. It does not incorporate any flow or any tissue movement. Only thing it does, it sets a platform of pressure above which the driving pressure works. And it is well seen that this energy takes a U shape. when the lower levels of the energy, it's protective, and a higher level of PEEP energy can cause villi. This energy is stored and is converted into heat mainly during exhalation. Now, when we say that PEEP does not actually take part in the energy development, what we need to know is, as the PEEP is increased, the baseline from which the driving pressure has to deliver the tidal energy keeps increasing. Every lung has got a point called the threshold point, where beyond which energy would cause villi. So as the PEEP increases, the driving pressure on top of it could cross the threshold energy level and then cause villi. So as long as the PEEP is low, it does not add to the energy that causes villi, but as it goes up, the baseline moves up, and the driving pressure or the tidal energy which is expended on top of it could move into the dangerous range and cause damage. Now, so far we were talking all about the inspiratory phase or the tidal energy. What happens during expiration? Is energy expended during expiration? Does it take part in villi? What we know is, as exhalation proceeds, the stored energy from the static and the stored part of the tidal energy gets released, and that forms a kinetic energy which allows the lung, which is completely expanded, if you look at this graph, to come back to its original form. So there is a lot of unfolding of the lung and remolding of the lung molecules, reshaping, folding, and de-recruitment happening, and energy is spent for that. What happens is, if this energy is released, all of a sudden it can cause injury to the lung. And the analogy that has been put forward is like a cup and saucer which is kept on a first floor, and if it is dropped all of a sudden to the ground floor, it shatters and causes problem. Whereas if the same cup is brought down in a step by step to the ground floor, it does not shatter. And this has been clearly shown in experimental studies using porcine lung, that if the expiratory flow rate is reduced, the severity of lung edema, lung damage can be reduced. Now, almost stored static energy is accounted for during expiration. However, there is a small amount of unaccounted energy, and what happens to that is the mystery. Now, the biggest concern is, does this unaccounted energy cause villi? Now, what is mechanical power? As shown in the second slide, power is nothing but energy expended per unit time. So it is inflation energy into ventilation frequency. So when you talk about power, in addition to the energy, we are bringing in frequency or flow into the picture. Now, it has been clearly shown that power is influenced by three components. One is the energy part, the inflation energy. The other thing is inspiratory flow and the ventilatory frequency. Experimental studies have clearly shown that when lung is ventilated, this is a graph from an experiment done with a rabbit lung, and when lungs were ventilated at similar tidal volumes but different frequencies, the damage done to the lungs which are at a higher frequency of 20 compared to 5 develops edema much higher, telling us that the frequency and flow rate are also important components when it comes to formation of villi. Okay, now power is, as I mentioned before, denoted in the units of joules per second or joules per minute or joules per hour, depending on the time unit that we use to calculate it. Now, let's come to micromechanisms and villi. Now, the question always we wonder is, the small amount of unaccounted energy that stays back in the lung parenchyma at the end of expiration, does it really cause damage? What we have seen over the years is that all these factors that we know then can cause villi, high tidal volume, high peep plat, high peep, high driving pressures, all these things, none of them on their own can cause villi. But when they work together, they cause damage. So what is it that actually causes damage? Or what is it that accelerates this damage? That we have got certain amplifiers of damaging energy and power. And that is where the micromechanics come in. The next few slides, I'll be talking about what are the amplifiers of damaging energy and power, mainly 5. They are the baby lung of ARDS, the heterogeneous environment of the injured lung, the lung parenchymal stress threshold, which I did touch upon, then the matrix or the interstitium of the lung, which has certain properties, which I would be talking about in the next few slides. Now, let's start with baby lung of ARDS. There are 3 important processes that happen in the baby lungs that makes villi happen. First is the small size and the high specific power. You look at this cartoon, in a normal lung which is ventilated with 6 ml per kilo, and the pressure generated comes to 30 centimeters of water, and the power is 4 joules per minute. If the same 6 ml is applied to a severe ARDS patient, lung with baby lung, even though the pressure may be same and the power may be the same, but the specific power, that is the power applied to unit area of the lung parenchyma, is much, much higher than 4 joules per minute. And this is what causes damage or increases the damage in the baby lung. The second process that increases damage is even when we are ventilating with a constant tidal volume of 4 to 6 ml, as the ARDS gets worse, the number of units in the baby lung keeps coming down. So the number of units into which the constant tidal volume goes in has to take in all the large tidal volume. The increase in stress and strain happens, and that is where further injury happens. The third process is a protective process. The baby lung, where when it sits in a highly inflamed or damaged area, is protected by the damaged area, and even though the pressure, the stress is transmitted into this alveoli, the volume does not increase. So that is one of the protective mechanisms that a baby lung could have. Now, let's look at the heterogeneous environment of an injured lung. We know that ARDS is a heterogeneous disease, and within the injured part of the lung itself, there are areas that are compliant and areas that are non-compliant. So when a compliant area of the lung, which has a PEEP of 5, is subjected to a driving pressure of 20, that could cause a large volume expansion, and that produces a huge strain on the alveoli. It gets overstretched, and the energy and power that this alveoli is put to is huge, and that causes damage. Whereas the non-compliant part of the lung, where the PEEP is 5 and is subject to the same 20 centimeters of water driving pressure, even though the strain comes to 25, the stress comes to 25, the volume does not increase, and the volume remains small, and the strain is tolerated. So the increased strain in the more compliant part of the heterogeneous lung worsens the disease process and the injury, and that's how the villi progresses. Now, let's look at the pressure time graph again. Now, we already saw the 3 vital energy components in this, but what we do not know is what is the threshold of energy that usually causes damage. Now, animal studies have shown that it's relatively high in normal lungs. So This part of the graph shows us the area where the damage can happen. So if we are experimentally able to find out the threshold beyond which injury can happen, maybe we can ventilate patients below the threshold pressure, thereby reducing the damage. So the high numerical values of power can be achieved without crossing high tidal threshold for normal lung, and that is why most of us do not get lung damage even when we do heavy exercises and have a rapid respiratory rate. Now, in an injured lung or an ARDS lung, the threshold may be considerably lower, and when we apply high energy and power, and if it goes beyond the threshold level, that's where the damage happens. Let's look at the lung interstitium. The lung interstitium, you see the electron microscopic picture here. It consists of interdependent microfibrils, which are neither resilient nor elastic. So they do not expand as well as the rest of the lung parenchyma does. So what happens is, when there is tidal inflation, these part of the lung do not move as well as the rest of the lung, and this can cause what is known as power amplification. And as power amplification happens within the interstitium, there can be overt rupture of this microelements. There can be tension built up in the interstitium and initiation of inflammatory signal. There are three processes that cause this, and we will go through them one by one. They are called the geometric stress focusing, the viscoelastic drag, and the progressive dropout of stress-bearing elements. Now, let's see what geometric stress focusing and viscoelastic drag are. Now, geometric stress focusing is more of a mechanical engineering terminology. It means nothing but it's the stress that happens at boundaries of tissues with different mechanical properties. So if there are two areas of the interstitium that has two different mechanical properties, that area becomes a weak point, and that creates an area of stress focus, and that can be an area of local power amplification, and that is where injury would start and progress. The second one is the viscoelastic drag. That happens when the lung expands and certain components of the interstitium does not move with the rest of the lung parenchymal tissue, lags behind, and this drag creates an added stress onto this area, which may already have a geometric stress focus happening there. And we all, as I mentioned before, these viscous drag stresses are more when we use higher flow rates. Now, dropout of stress-bearing elements, that is nothing but when this matrix of interstitium, which bears the brunt of the energy and power, become weak. There are certain areas which are more weak and starts breaking. So for example, as shown in this cartoon, if there are 6 of this fiber, which takes on to about 12 kilos of energy, and if 3 of them break, the what was shared as 2 kilos per fibril becomes now 4 kilos per fibril, and there is more energy applied on this rope, which makes them more vulnerable, and the support is lost. And as the transfer of this entire stress goes on to this fewer number of microfibrils, there is more breakage, and the whole process gets accelerated. And once this process gets accelerated, damage happens in an exponential factor. Now, it's not only these factors that play a role in influencing Willie. There are also non-mechanical factors which do. Here is a microscopic electron microscope appearance of an ARDS lung. where you see 3 alveoli, one filled with edematous fluid. That is the surfactant, which is getting collected in the fluid. You can see the epithelial cells, endothelial cells, the membrane in between that being thickened. So what are the non-mechanical factors that can make this worse? Any increase in the mean pulmonary artery pressure can increase lung edema. Anything that increases cardiac output can increase the mean arterial pressure, widen the vascular gradient across the alveolar, and increase the edema again. And the increased gradient of the microvascular pressure can increase energy and cause disruption of the endothelial cells. And when there are a big difference in the pressure generated, there can be vascular surge of energy across the endothelium, creating injury. This happens when patients with ARDS are ventilated and allowed to breathe spontaneously. There are areas of the lung that moves from West zone 2 to 3, and this deflation causes an increased surge of energy and damage. And this is a point that is always discussed around spontaneous breathing in people with lung injury and how maybe spontaneous breathing should be limited. And definitely high use of inspired oxygen too can cause it. So in conclusion, what have we learned over the last 2 decades? Our understanding of how villi happens has rapidly changed. Flavor of the decade is to prevent cumulative injurious strain. What we know is none of these factors on their own can cause a villi. They have to act together. The debate that is on is what is important. Is it the global tidal energy, or is it just the tidal elastic energy that causes the damage? But at the same time, it's not only an energy, we should also not forget ventilatory frequency, inspiratory flow, the duration for which stress and strain is applied onto the lung. Don't forget the expiratory phase too has a role, more of which we'll need to learn more about it. And there are non-mechanical factors too that come into play. The micromechanics and the matrix are hot at that moment, and the stress focus and local application of power at these interstitial areas, which are weak points, is also thought to be a cause for villi. And to have villi, there are 2 things that need to happen. There should be a damaging level of power, and this power should be there for a long period of time. If these 2 factors are not there, villi will not happen. Now, for a damaging level of power to happen, there are things that should be there. We already spoke about it, along with high frequency of stress cycles. Now, to make the factors that produce damaging energy in every tidal cycle, we have the stress amplifiers, which we spoke about, the baby lung, the heterogeneity of the injured lung, and the viscoelastic property of the lung, and the dropout of stress-bearing elements, along with non-mechanical features like vascular pressure and flow, basal lung inflammatory stage, all which add on to increasing the power. Thank you very much.
Yeah, Dr. Tejas, you can unmute yourself.
Yeah, thank you very much, Dr. Babu.
Dr. Tejas.
Thank you very much for this beautiful discussion. You have my sincere thanks and appreciation. To be honest, this was a macro discussion on the micro mechanical causes of villi, and there are a lot of about the understanding of and the machine, that is the ventilator interaction. Continues this saga, we will have our next topic, that is lung and diaphragm protective ventilation, why and how, by none other than Dr. Samir Job. Dr. Samir Jog is a senior consultant intensivist from Dinanath Mangeshkar Hospital, Pune. He is specially interested in ECMO, mechanical ventilation, and tropical disease. Let me tell this, that he is intensivist to get faculty invitee at Brussels International Symposium in Intensive Care and Emergency Medicine Conference. That is a very prestigious conference, and he is the only Asian intensivist to get European Society of Intensive Care Medicine's honorary life membership. So let's hear about lung protective ventilation from Dr. Samir Jog. Over to you, Dr. Samir.
Hello, good morning, everybody. I'm Dr. Samir Jog. Since I'm not present in front of you physically, I have to introduce myself. And I'll be talking on lung and diaphragm protective ventilation, why and how. Over the last 20-25 years, we have learned that ventilators are not completely safe and they are associated with some kind of injury to the lungs. And these injuries are classified as barotrauma due to high plateau pressure or high transpulmonary pressure, if we measure esophageal balloon pressure. Then volume trauma because of high tidal volumes, especially in ARDS, more than 6 ml per kg, or for a normal lung, more than 8 ml per kg of predicted body weight. Atelic trauma because of cyclic opening and closure of alveoli, adjacent alveoli get rubbed upon each other and may cause injury to the lungs. Biotrauma, it's kind of unavoidable situation where if a patient is put on mechanical ventilator, there is some amount of cytokine release in this patient sheer because of positive interthoracic pressure due to mechanical ventilation, which is unavoidable kind of injury. And recently, ergotrauma has been described, which is nothing but a power transmission from ventilator to patient, and which is dependent on respiratory rate, flow of gas from ventilator to patient, driving pressure, and positive and expiratory pressure. Besides this ventilator-induced lung injury, VIDD, that is ventilator-induced diaphragmatic injury, is now becoming more and more obvious, and there is a focus on this area in the last few years. So what is VIDD? It is nothing but, maybe you can call it as an iatrogenic injury to the diaphragm due to mechanical ventilation. Simple to understand. So if somebody is put on mechanical ventilator, that positive pressure ventilation and forceful ventilation itself may cause diaphragmatic atrophy, injury, and subsequent weakness of the diaphragm and intercostal muscles. In this lecture, when I say about diaphragm, it is assumed that it is applicable to intercostal muscles and other accessory respiratory muscles as well. So it's a muscular injury due to mechanical ventilation when I say diaphragmatic injury. Unfortunately, there is no established approach for diaphragm protective kind of ventilation, and the new research or new focus is on this aspect, which we will be discussing in few minutes. So what is lung safe ventilation or lung protective ventilation? To categorize this, I have categorized simple approach, or I have taken simple approach that we normally ventilate 3 kinds of lungs in our ICU. If we categorize the lung pathologies, first and foremost, I may say most common reason why we ventilate patient is patient lungs are normal, but they have to be on mechanical ventilator. And the classic examples are large intercerebral bleed, subarachnoid hemorrhage, respiratory failure related to shock, Guillain-Barré syndrome, organophosphorus poisoning, where brainstem stroke, where the lungs are by and large normal, but either inspiratory drive is abnormal or completion of breath and exhalation is abnormal. So this class of patient, our ventilator strategy has to be completely safe and should not cause any injury to the native lung. And for such kind of patient, we usually choose tidal volume of 6 to 7 ml per kg of predicted body weight. But if there is significant tachypnea, we have to use sedation to maintain low tidal volume, but we may go up to 8 ml per kg of predicted body weight. So 6 to 8 ml per kg of predicted body weight is the safe range for normal lung when we ventilate these patients. Then plateau pressure has to be kept below 20-22 centimeters. At any cost, it should not go beyond 25, because as it goes beyond 25, the issue of barotrauma comes into play. So for a safer lung, we have to keep plateau pressure below 20. Same is true about driving pressure, which has to be kept below 15. Then if you measure esophageal balloon pressure, then transpulmonary pressure has to be kept below 15 to 18 centimeters of water for a normal lung. I'm not talking about ARDS, for normal lung. And respiratory rate has to be below 25 per minute, because we have learned that ergotrauma is dependent on more respiratory rate or higher respiratory rate. FiO2 has to be below 0.6 and PEEP has to be optimal. And optimal PEEP, you can adjust the PEEP depending upon your saturation, depending upon your PO2, depending upon your lung mechanics. And by and large, this lung, we are talking about a normal lung. So the PEEP may not be required more than 5 to 6 centimeters of water. So these are the settings of lung protective ventilation for a normal lung in our ICU. And the examples we have already discussed. The second type of respiratory failure we treat by mechanical ventilation are obstructive airway diseases. The classic ones are acute exacerbation of COPD or life-threatening asthmatic episode, where we have to intubate these patients and ventilate them mechanically. In home, the tidal volume is of crucial importance, because we don't want to hypoventilate these patients, because of their main problem is CO2 retention and CO2 narcosis. So our tidal volume has to be sufficient, which can be up to 8 to 6 ml per kg of predicted body weight, preferably 8. But when we choose a higher tidal volume like 8 ml per kg, our plateau pressure should not go beyond 30. That's the safety limit. By and large, in this patient, the problem is of respiratory airway, that is resistive problem, than a compliance problem. If we measure esophageal balloon pressure in this patient, especially during weaning, the pressure swings or negative pressure at the beginning of inspiration should not be more than 15 centimeters. This will protect the diaphragm as well as lung. Respiratory rate should be kept below 35. When under control ventilation, we typically keep rate between 12 to 16 breaths per minute. But when we are allowed to breathe spontaneously on pressure support ventilation, the higher RR may lead to expiratory limitation of single breath and may lead to dynamic hyperinflation and CO2 retention. So respiratory rate has to be controlled even during weaning of these patients. FiO2 has to be below 0.6 to avoid oxygen-related toxicity or oxytoxicity of the lungs. And PEEP again has to be optimal when we are ventilating this patient under deep sedation or paralysis with controlled mechanical ventilation. The choice of PEEP depends on the saturation or oxygenation. If saturation is very low, we may dial a PEEP of 6-8 ml, depending to get better saturation above 88-89%. And when we wean this patient on pressure support ventilation, the optimal PEEP is at least 80% of intrinsic PEEP. So before switching to pressure support ventilation, we should measure intrinsic PEEP of these patients, and at least 80% of this value has to be supported from the external PEEP. This will avoid excessive work of breathing during the spontaneous breathing by these patients, which will protect the lung and which will protect the diaphragm as well. So this is the strategy which we use in obstructive airway disease. And the third kind of diseases which we treat in our ICU are like ARDS diseases. And there's a heterogeneous group which are commonly called as diffuse alveolar diseases. ARDS is a part of that, maybe lung contusion, gas inhalation injury, eosinophilic pneumonias, hypersensitivity pneumonias, all of them, graft versus host lung disease, all these diseases typically have parenchymal affection with low compliance and a problem with the oxygenation. So in these kind of diseases, we typically choose tidal volume of 6 ml per kg, which has been proven beyond doubts is lung protective. But this per kg is predicted body weight and not on actual weight of the patient, and it depends on the length of the patient. Then in these patients also, plateau pressure we want to keep below 30 centimeters, which has been protective. Driving pressure has to be below 15 centimeters of water, and which has been shown to be protective and associated with better outcomes in these patients. Transpulmonary pressure has to be below 25, above 25. The issue of barotrauma definitely comes into play. Respiratory rate more than 35 is not something which is advisable, which may lead to significant good trauma or atelic trauma. FiO2 length has to be below 0.6 to avoid oxygen toxicity. Optimal PEEP I've just written optimal PEEP because there are at least 9 to 10 validated methods of dialing PEEP in ARDS patient. It may be depending upon inflection points, it may be depending upon ARDS net table, it may be depending upon right ventricular study by echocardiography. So you choose the method of your choice to choose appropriate PEEP, but the target should be lung recruitment 1 and optimal gas exchange to maintain saturation around 88 to 89%. Prone position has been effective in ARDS ventilation or ARDS-like pathologies, and it is associated with significant recruitment of lung as well as lung protection. So you can use lesser amount of PEEP, lesser amount of driving pressure in this position. And early use of neuromuscular blockade in early chronological period of severe ARDS has been protective because you avoid a lot of asynchronous during this severe period of ARDS, and you allow the ventilator to deliver the tidal volume, the PEEP, the flow exactly which you want to deliver, and there is no resistance or there is no issue from the patient's end. So neuromuscular blockade in early part of ARDS has been protective for the lungs. Sedation for lung protection is important. If patient go on breathing at a rate of 35 to 40, ultimately he will fatigue. Not only will fatigue, his diaphragm will undergo significant injury because of asynchronous respiratory efforts. So we have to maintain sedation for patients who undergo mechanical ventilation, and our common target on the Richmond agitation sedation scale is around 0 to -1. Sometimes we choose a deeper sedation like -2 or -3 in early period of ARDS, or during COPD controlled ventilation, or we want to control intercerebral pressure, we will keep deeper sedation. But otherwise, the target is usually between 0 to -1. The sedation target should be such that spontaneous trigger has to be maintained as far as possible. Barring these few conditions, the spontaneous trigger or spontaneous inspiratory trigger has to be maintained. That is protective for lung and more protective for diaphragm. Appropriate sedation should be used to avoid tachypnea and asynchrony, and use of inspiratory and expiratory oxygen pressures to assess diaphragm function, which we'll discuss after a few minutes. And you have to adjust the sedation depending upon these pressures. Neuromuscular blockade. By and large, neuromuscular blockade we avoid their use in ICU, but there are conditions like severe ARDS in early course, when we are doing prone position with higher PEEP, when we are using controlled mechanical ventilation, acute exacerbation of COPD or asthma ventilation, we have to use neuromuscular blockade in ICUs, but their use should be minimal. And they commonly use neuromuscular blockade in such condition as well as when there is significant asynchrony, which leads to hypoxia or hypercarbia. We have to use neuromuscular blockade to provide synchronous ventilation to patients. But their routine use should be avoided in ICUs. The concept of passive hypercapnia must be touched upon when we talk about lung protective ventilation, because if we set certain gas targets for mechanical ventilation, we may be wrong and we may be producing more and more injury to the lungs. So we accept little higher carbon dioxide when we ventilate ARDS, and for which the pH target is 7.15 to 7.2. If our patient's pH is remaining in this range and above, then we accept PCO2 maybe up to 70, 72, 68 millimeters of mercury as well. And we don't treat that CO2 just for the number's sake, as long as the pH remains stable in acceptable range. So this is called as permissive hypercapnia. We allow the carbon dioxide to remain in the body so that the deleterious effect due to pH are not seen in this patient. And this CO2 is well tolerated by many ARDS patients, and we don't have to do much adjustments on ventilator to just wash out this CO2. So this is higher CO2 we accept to protect the lungs is permissive hypercapnia. And sometimes if the CO2 is very high and we have to use higher respiratory rate, higher tidal volume, we just wash out of CO2 and treat respiratory acidosis. We may use extracorporeal CO2 removal. In this process, we remove the carbon dioxide by extracorporeal circuits or mini ECMO or respiratory dialysis. We choose the terminology, whatever you like, but the principle is the same. And in such scenarios, we can use very low tidal volume, up to 3 ml per kg of predicted body weight, and literally hypoventilate this patient. And the subsequent carbon dioxide retained is washed out by extracorporeal CO2 removal. So permissive hypercapnia is important. Same as permissive hypoxia. The recent focus in ICU research is on what is the best oxygenation level in majority of our patients? And the answer is not same for all the patients, but by and large, in a stable patient in ICU or mechanical ventilation, if the saturation remains around 90 to 93% is acceptable for most of our patients. We should not target unnecessarily higher saturation like 95% or 97% in most of our patients. Especially nowadays, 88 to 89 is acceptable. So if we accept this 90-91% of saturation, we will be using less and less oxygen, which will avoid oxygen-related toxicity to the lung, and we will be using less and less PEEP, which may avoid the lung stress due to higher bladder pressure and barotrauma. So if we set a low target, our ventilation will be more gentle and more protective. I will just touch upon the recruitment maneuver, which had been popular a few years back, but now there is adequate data that routine use of recruitment maneuver is not recommended in the ARDS. We may use recruitment when hypoxia becomes very severe. For example, saturation drops to 72%, 71% if the respiratory circuit is disconnected or during suction or during bronchoscopy. At that time, we may use recruitment maneuver to gain the previous recruitment of ARDS lung. And in permissive hypoxia, there is a role of judicious neuromuscular blocker that if the patient is getting hypoxic because of asynchrony, then we may give a small dose of neuromuscular blocker to avoid dysynchrony and accept saturation around 90%. Ventilator-induced lung diaphragmatic injury, which we already have described, and I'll be taking next few minutes on this ventilator-induced diaphragmatic injury. The diaphragm dysfunction classically occurs by this pathogenesis. One, if we use excessive sedation or over-assist the patient with mechanical ventilation, then the patient's own drive is gone or his own efforts are gone, and which will lead to diffuse atrophy of diaphragm. Diaphragm is skeletal muscle, which will obviously undergo diffuse atrophy if we don't use. So if we don't use, we use it. Simple principle of physiotherapy. Then excessive PEEP, if we use excessive PEEP, then we may induce expiratory myotrauma to diaphragm and respiratory muscles, which will lead to longitudinal atrophy of diaphragm and respiratory muscles. If we choose the wrong setting, especially very low flows or very high PEEP or very high tidal volume or ventilation, which will lead to expiratory dysynchrony and may lead to eccentric load injury to diaphragm. If we undersedate the patient, when actually patient asynchrony is seen, if we use less amount of sedation, which will unnecessarily lead to excessive effort by patient and which may lead to load-induced injury to the diaphragm. And if our ventilator setting is inappropriate in the sense it is less efficient ventilation or less appropriate or less than required ventilator support, then obviously diaphragm will work more, which will again lead to load-induced injury to the diaphragm. So this is a rough idea how ventilator or how our wrong settings or how a disease can lead to diaphragmatic dysfunction. So are there any ways how we can avoid this diaphragmatic injury? So diaphragm protection targets are basically there are three targets we can choose in our routine mechanical ventilation. We should keep modest inspiratory effort. Then we should maintain synchronous expiratory cycling and avoid excessive expiratory braking, which we'll see in the next few slides. One modest inspiratory effort for which classical useful method is measuring esophageal pressure, and if the esophageal pressure swings are below 10 centimeters or rather negative 10 centimeters, then that is the appropriate diaphragmatic action. If the esophageal pressure swings are more than 15 centimeters, that's an excessive inspiratory effort. Then diaphragm thickening fraction, which we just talk about sonography in diaphragm after a few slides, but it is just remember the number that if a diaphragm thickening fraction, it should be kept around 15 to 30%. It cannot be modified, but if it is between 15 to 30%, it is better protective for diaphragm. If it is less than 15 or more than 30, it is not protective for the diaphragm. Synchronous expiratory cycling. So prevent premature cycling by adjustment of flow, especially expiratory trigger flow triggering. Many ventilators has got this button available or adjustment available, and ineffective effort during expiration should be curbed by appropriate sedation adjustment, as we discussed about the Richmond scale. Third, avoid excessive expiratory braking, which is nothing but the continued contractile activation in expiratory phase, and this can be achieved by adequate amount of PEEP, which supports the diaphragm, external pressure support to the diaphragm, and adequate amount of sedation can prevent this contractile activation during expiratory phase. Three simple monitoring tools which are available in most of our ICU ventilators can be utilized. One is early airway oxygen pressure, which is popularly called as P0.1, which is typically a measurement of negative inspiratory effort during first 100 milliseconds of the inspiration, where there is no flow from the ventilator, which actually quantifies the respiratory drive of spontaneous breath. Higher negative values means there is a stronger drive, and the quantification is as follows. If the drive is below 1.5 centimeters, then it is over assistance or patient is not adequately triggering. And if the PEEP 0.1 value is more than 5 centimeters, this means the patient is not getting adequate amount of ventilator support, or his drive is appropriate and he can be considered for weaning, especially his inspiratory drive is good. So weanability can be assessed by this. Second, expiratory oxygen pressure. When we put the expiratory oxygen pressure, which we commonly do to measure intrinsic PEEP, when we do this and when patient is not under paralysis or not under deep sedation, most of our patients will have an effort of inspiratory effort. If their diaphragm is triggering well or respiratory muscles are triggering well, they will have inspiratory effort, which is shown in this diagram. And this negative inspiratory swing, this pressure measurement can be done on our ventilator graphic screen. And this is called as occlusion pressure or delta occlusion pressure. What does that tell? This expiratory occlusion pressure often tells us about respiratory muscle pressure exerted by patient's diaphragm and respiratory muscles, with esophageal pressure monitoring, which can detect transpulmonary driving pressure also from this. And the quantification is if occlusion pressure is more than minus 15 centimeter, this means the diaphragm and respiratory muscles are having good effort, and this means this patient is probably ready to wean. At least his trigger is good and his muscle power is good, so he can generate a reasonable amount of tidal volume if we put this patient on spontaneous breathing mode. So that is the conclusion of this P occlusion pressure or POCC. Third tool, which we commonly use during control ventilation, but we rarely use this knob or ventilator on pressure support ventilation. When we ventilate on pressure support or weaning mode, if we put an inspiratory hold button, we can measure plateau pressure, which we commonly use during control ventilation. So this is the same method, and we can use a plateau pressure, or we can measure plateau pressure, provided patient do not take an additional breath, which commonly happens in pressure support ventilation. But if patient is under appropriate sedation, maintain his trigger well, and if we give inspiratory pause for a longer period of time, say 4 seconds, 5 seconds, then if you see in this graph that pressure gradually stabilize, which is the plateau pressure. All of us know this, right? So this is measurement of plateau pressure in pressure support ventilation. And look at these numbers. This patient is on PEEP of 10 centimeters with pressure support of 10 centimeter. And when we measure plateau pressure in this, the plateau pressure is actually 28, and the delta pressure or driving pressure is 18. 10 plus 18 is 28. So this means plateau pressure is actually more than 15, one, and that plateau pressure is more than the peak pressure as well. So what is happening? Patient is causing actually active effort when we put an expiratory pause. So that's why the pressure increases. So meaning of plateau pressure more than peak pressure is active expiration by the patient, and delta pressure more than pressure support is actually forceful expiration. So this means whatever amount of support we are giving to this patient can be definitely reduced. This is the conclusion of this test. So this test can be simply done in our routine mechanical ventilation. Then there are some higher technologies or newer technologies applied to study diaphragm in detail, and NAVA is one of them. NAVA is neurally adjusted ventilatory assist. That is the full form of NAVA, in which the principle is this catheter is passed like rice tube, and it sits into gastroesophageal junction and actually measures the diaphragmatic electrical activity. So now the catheter itself is nothing but the measurement or EMG of a diaphragm. So in single understandable language for us is actually EMG of a diaphragm, electromuscular brain activity of the diaphragm. So EADI is electrical activity of diaphragm. And EADI signal is calculated in NAVA, which calculates the frequency and the intensity in microvolts. The mechanical inflation, the contraction of the diaphragm and mechanical inflation often starts when EADI is more than 0.5 microvolts. When diaphragm electrical activity is more than this, diaphragm starts contracting. The correct pressure support proportional to diaphragm contraction is provided with this NAVA mode, or it's basically pressure support mode, but the adjustment of pressure support is variable in every breath, and even during the breath, during the inspiration, the flow is adjusted dynamically during each breath, depending upon the electrical activity of the diaphragm. So just focus on this pressure time scaler. What the yellow one, which I'm pressing with the cursor, is a pressure support. This is a peak level, and the white graph is actually electrical activity of the diaphragm. You can see this, the actually inflation of lung with the help of pressure support starts much later, few hundred milliseconds after the electrical contraction of the diaphragm starts. So actually patient feels air hunger during this period. The diaphragm is contracting, but the ventilator is not supplying any gas flow. Similarly, during expiration, what happens? The machine is exhaled, but during late part of expiration, the diaphragm starts contracting, but there is no gas flow during this. So diaphragm starts contracting, but the gas flow is not given. So this is expiratory asynchrony, or the previous was an inspiratory asynchrony. So NAVA can avoid this because the pressure support starts with the electrical activity of the diaphragm. So it can prevent over-assistance myotrauma, it can prevent under-assistance diaphragmatic injury, and NAVA is claimed to give better synchrony in pressure support ventilation with optimal sedation. Another technique to perform diaphragm protective ventilation is use of esophageal balloon catheter, which measures transpulmonary pressure. And this screen shows the transpulmonary pressure. Just focus on this fourth scalar from top, which is shown in the orange graph. During the expiration, the pressure goes below the isoelectric icon 0 line, and during expiration it comes above it. So this means during expiration actually the lung collapses and intrathoracic pressure becomes negative. So this transpulmonary pressure can be applied to give adequate protection to the diaphragm. We'll see an example how it can be used. Just see this pressure times scalar in a COPD exacerbation patient. We are meeting this patient with peak of 5 and pressure support of 10. The tidal volume generated is around 500-550 ml. The gases are well acceptable, and 2 hours later, what happens? Patient becomes tachypneic, tachycardic, desaturates, and has significant distress. So we had to sedate the patient and return to volume control ventilation. What happened in these 2 hours? We are supporting pressure support of 15 centimeters, and if we see the esophageal pressure monitoring here, there is significant pressure swing during inspiration. So patient's diaphragm and respiratory muscles are significantly contracting to develop negative intrathoracic pressure to start inspiration. So this is a negative swing. On top of that, we are adding pressure support of 15 centimeter, which is a positive pressure support. So in a single breath, the pressure swing is from -15 to +15, that is 30 centimeters of water. So this significant pressure swing will lead to lung trauma and diaphragm fatigue together. So this is typically happens in a weaning failure patient. So we have to give appropriate PEEP, appropriate sedation, and appropriate pressure support. So measurement of transpulmonary pressure or measurement of esophageal pressure will guide us in choosing PEEP, pressure support, and sedation for this patient. So this weaning-induced phenomena is described here. High LV afterload, new lung stress, and ventilator-induced lung injury may start with this. Another example is when we wean the patient either on TPs or pressure support ventilation. There are 3 possibilities. We just disconnect the patient from ventilator and apply TPs. There is no positive and expiratory pressure applied, and no pressure support is applied. It is just T-piece oxygen or T-piece air is supplied to the patient. And just see how the pressure swings are there in this patient. If this pressure swings, esophageal pressure swings are significantly higher, this means this patient probably require some amount of PEEP and some amount of pressure support during his weaning process. So when we apply just pressure support of say 8 centimeters of water or 7 centimeters of water, the esophageal pressure swings are reduced. And when we apply PEEP to this pressure support, esophageal pressure swings are further reduced. So patient is comfortably breathing without exerting diaphragm to do more and more contraction, and diaphragm will not go to fatigue. So this is the application of transpulmonary pressure measurement or esophageal balloon pressure measurement, which will give us some clue to adjust pressure support as well as PEEP when we wean this patient on pressure support ventilation. So this slide narrates the utility of transpulmonary pressure in diaphragm protection to detect diaphragm overaction, to choose optimal PEEP and pressure support, and to choose optimal amount of sedation. The last topic is diaphragm study by ultrasonography, which is quite popular in sonography loving people. And the 3 common parameters which are used when somebody studies diaphragm by ultrasonography is diaphragm thickness, diaphragm thickening fraction, that is how much thickening occurs during inspiration. We can actually measure this diaphragm, and excursion of the diaphragm by M mode. So what are the purposes of this study of diaphragm by ultrasound? To study diaphragm size and function over the time. We can compare the diaphragm parameters 24 hours back, and we can compare this after 24 hours. So we can have a chronological comparison. Then to assess and diagnose diaphragmatic dysfunction, there are certain parameters which we discussed, and to predict weaning success. This is little ambitious at present, but maybe in future we will be using routine sonography use to decide or to add to our knowledge of weaning. So diaphragm thickness can be easily calculated by a good ultrasound machine. During expiration between these 2 dips, we can locate the diaphragm and we can see this diaphragm. During inspiration, obviously when diaphragm contracts, the thickness increases, and the thickness is obviously seen more in this picture. So diaphragm thickness can be easily measured. So extreme thinning of diaphragm below certain level can be labeled as diaphragm-induced or ventilator-induced diaphragmatic injury, but the algorithms or number validation is still not yet validated so far scientifically. The second parameter for diaphragm study is diaphragmatic excursion. At the end of expiration and at the end of inspiration, on M mode especially, we can actually measure the movement of diaphragm during the respiratory cycle. And if this movement is suboptimal, we may conclude that diaphragm has having significant dysfunction, and this patient may not undergo good weaning. So that's a little far-fetched interpretation of these parameters, but in future we may be talking in these terms. And diaphragm thickening fraction is so far reasonably studied. The thickening fraction is calculated as diaphragm thickening of diaphragm at total lung capacity minus thickening of diaphragm at FRC divided by diaphragm thickness of at FRC. And if the thickening fraction is less than 15%, this means this patient is getting over assistance by the ventilator. Diaphragm is not adequately contracting, or diaphragm is not allowed to contract adequately because the job is done by ventilator. And if the diaphragm thickening fraction is more than 30%, this means the diaphragm is vigorously contracting and ventilator is not providing adequate support to the respiration. So diaphragm has to work more in this patient. So if thickening fraction is more than 30%, there is under assistance by the ventilator. But the other meaning of this is patient is probably ready to wean because he doesn't require ventilator support. This is also good logic when the thickening fraction is more than 30%. So diaphragm study by USG, these are 4 parameters. Speckle tracking is a new parameter, but I won't go into that detail in this lecture because it is still a new science developing. So these parameters are not yet calibrated and validated. For example, we know a plateau pressure of 30 and more is deleterious. We know a tidal volume of 6 ml per kg and more is deleterious. So that kind of numbers are not calibrated and validated in diaphragm protection. So very few studies in ventilated patients, and these parameters are not yet fit for decision making in our day-to-day practice currently in 2021. Maybe after 4-5 years, when the validation occurs and calibration occurs of these parameters, we will be using these parameters maybe on NAVA, maybe from esophageal pressure, or maybe from ultrasound to make accurate decisions about adjustment of P, adjustment of pressure support, or adjustment of sedation, or decision of weaning in our patients. Last point, when there is a conflict between lung protection and diaphragm protection, the precedence should always be given, or importance should always be given to lung. So priority is lung and then the diaphragm. Thank you very much. Thank you for attending this lecture. And if you have any questions, I'll be available at the end of the plenary lecture. Thank you very much.
Dr. Tejas, you can unmute yourself.
Yeah, thank you, Dr. Jog. That was really an enlightening presentation. And we now know that there are a lot more to understand about the man and the machine interaction. But friends, don't go anywhere. The Pune connection continues for these ventilatory plenary sessions. May we present our next speaker, the Dr. Shirish Prayag. Dr. Shirish Prayag is a chief consultant in critical care medicine at Prayag Hospital, Pune, and he is one of the founder members of ISCCM in India. He is going to talk on the topic monitoring driving pressure and its implications. Over to you, Dr. Prayag.
Good morning, all of you. I'm Dr. Shirish Prayag from Pune. This morning, my topic for the discussion at this plenary session is going to be monitoring driving pressure and its implications in mechanical ventilation. It's always a pleasure to be associated with the ISCCM's National Congress. It's been the 27th consecutive year that I've had the honor of being a faculty at these plenary sessions. And it's always a great privilege to be back to discuss any new topic. Unfortunately, this year we can't meet personally and physically, and it has to be a virtual meeting. Nevertheless, the pleasure is always there. And I hope that this morning's discussion will lead to something fruitful in the field of mechanical ventilation. I have no disclosures in regard to this particular talk. This morning, we are going to discuss driving pressures. And when we talk of driving pressures, we are going to elucidate the physiological concepts of the driving pressure. What is the evidence for using driving pressures in mechanical ventilation? How do we measure it actually at the bedside? And is there any role of actually doing the ventilator settings with the help of driving pressures and its implications in terms of its usage at the bedside while we are ventilating our seriously ill patients? And of course, what is going to be the future of the driving pressures in general? When we talk of the most difficult type of ventilation in the field of critical care, it's related to ARDS. We know that the difficulty comes because of the high mortality and also because the main supportive strategy that we use for treating patients of ARDS is the mechanical ventilation. And this itself tends to bring in what is called as ventilator-induced lung injury. The ventilator-induced lung injury, which was previously thought to be related more to pressures and then evolved subsequently in our understanding by understanding that it's not just the amount of pressures, but it's the distending volumes and the atelectasis and the stress and strain of the mechanical power that we are actually using to ventilate these patients, which is causing the injury. Unfortunately, this is indistinguishable radiologically and clinically from the features of ARDS, and therefore is quite missed many times when we as clinicians are treating. The important components of ventilator-induced lung injury are now getting understood. As a result, we are banking our strategies for mechanical ventilation on two major principles. And one is to use what we call as lung protective strategies, which means we make settings on the ventilator which are not going to hurt the lungs, even if they may not help them, but certainly it should not help them. And then within those strategies, try and see if we can open the lungs and make sure that the gases exchange is better. So principally, we have moved from the strategies of trying vigorously to correct the abnormalities on blood gas analysis that we used to try and attempt. Our initial attempts were always that we should be correcting hypoxia, we should be correcting the PCO2 increase, we should be correcting the respiratory acidosis and so on and so forth. But today we say that, okay, let's first not cause any harm, not cause any damage, avoid the complications of mechanical ventilation. And all these are based on three particular pillars. And these are lower tidal volumes, lower plateau pressure, and higher PEEPs. And on these three principles, we try and erect our strategies to protect the lungs. When we try and use these strategies, we have realized that there is conflicting response to the manipulation of these separate components of lung protection. By this, I mean that suppose if I try and increase the PEEP, then we realize that the plateau pressures are pushed up and the low tidal volumes and low plateau pressures are actually speaking two sides of the same coin of trying to deliver the mechanical stress and strain on the lungs. So when we try and use volume limited modes, essentially the plateau pressures may vary. And if we try and use the pressure limited modes, the tidal volumes may shoot up beyond 6 ml per kg, which is what is advocated. So trying to optimize one component may negatively affect the another. And it is often unclear at the bedside, what should we be preferring? And should there be a unifying goal in trying to apply protective strategies in these patients? Over a period of time, we have realized that essentially it means that we should be reducing the overall power, overall energy that we are applying to the lungs through the mechanical ventilator in order to make sure that the stress and the strain on the lungs in terms of the deformities, in terms of the volume deformity, and in terms of the pressure supplied should be reduced. And if possible, there should be a single unifying factor which would represent as a surrogate marker of the energy and power that we are trying to use on these patients on mechanical ventilation. Is driving pressure this surrogate marker of energy or power applied during ventilation? Is a key question which has been haunting the real hard taskmasters in field of mechanical ventilation right from the late 90s. Amato, for the first time in late 90s, tried to define the driving pressure and tried to say that that is the unifying goal. Let's understand what is this principle of driving pressure. When we set the tidal volume, when we do a CT scan of an ARDS patient, we realize that in addition to the atelectatic and consolidated zones of the lungs, we have a small zone of lung which is normal. And this is what is called as a baby lung. This is the tiny component of the lung which needs protection. Now, when we set tidal volumes, actually, we always set them on the basis of predicted body weight because that's the lung size that we are predicting this patient to have. Which means that if there are two patients of, let's say, 70 kg weight, then for both patients of ARDS, we are trying to set tidal volumes at 6 ml per kg of ideal body weight. Now, both these patients may have entirely different amount of ARDS, different amount of consolidation and therefore differing amounts of the normal lung which is left in these patients for ventilation. And as a result, if we apply the same pressures or the same tidal volumes to both these pressures entirely on the basis of just the predicted body weight, then for two different patients with two different physiological components of the lungs, we are applying the same energy or the same power. And this is not really appropriate. So it was thought that we should be applying this power or the pressures or the volumes to these lungs in proportion to the amount of normal lung these have, or in proportion to the compliance of these lungs that they have. So normalizing the tidal volume to compliance and rather than to the body weight, and using this ratio as an index to indicate the functional size of the lung, is now regarded as a better predictor of outcomes in patients with ARDS rather than setting the tidal volume by ideal body weight alone. Now, when we look at the compliance of the lung, we realize that this is tidal volume per change in the pressure or per delta pressure change that we get. So the amount of change in the tidal volume as per the unit of pressures that we are applying is what we call as compliance. Now, you turning this same equation around, therefore, the change in the pressure or the delta pressure or the driving pressure is equal to tidal volume divided by compliance. So if we want to deliver a tidal volume based on the size of the compliance, if the compliance is high, then the tidal volume can go up high. If the compliance is low, then in order to maintain the driving pressures, we need to use a lower tidal volume. This is the way in which we understand what driving pressures are. And for routine bedside calculation of driving pressures, especially in situations where the patient is not making any inspiratory efforts, the driving pressure is equal to the plateau pressure minus the end expiratory pressure. So if you look at it diagrammatically, the difference in the the difference between the plateau pressure and the end expiratory pressure, which is related to the tidal ventilation. This is the energy which is applied. And this difference is known as the driving pressure. And the same depicted in this, wherein the tidal volume depends basically the tidal volume related to the FRC is the amount of strain that is being produced in these lungs, and the pressure at which this tidal volume is being generated is the driving pressure, which is the difference between the plateau, and the PEEP as seen in this figure. How do we measure it at the bedside? Basically, it's very simple. The patient should be sedated and paralyzed, shouldn't be making any inspiratory effort per se. And when he is not making any inspiratory effort, you calculate the plateau pressure. In many ventilators, it is shown regularly as a monitored variable. In some, you have to actually push the inspiratory hold and calculate the plateau pressure, and minus the total amount of PEEP in these patients. That's the driving pressure. So driving pressure is the plateau pressure minus the total PEEP, which is equal to the tidal volume divided by the compliance. Okay, if you want to make an accurate measurement of plateau pressures, there are certain things that we need to bear in mind. One is that the alveolar pressure, the flow has to be zero, which means that the patient has to be sedated and paralyzed. The plateau pressure is measured at the end of an inspiratory pause during volume controlled constant flow ventilation. It shouldn't be at the peak of inspiration, but it should be at the end of an inspiratory pause. And in pressure limited or pressure controlled ventilation, it should be at the end of inspiration. Now, during volume limited modes, an inspiratory pause greater than or equal to 3 seconds provides the best accuracy for plateau pressure measurements in normal and diseased lungs, which means that the pause has to be quite significantly greater if we want to measure the accurate plateau pressure. And if the pause is shorter than 0.5 seconds, then there is an overestimation of the plateau pressure by 11% in patients of ARDS and 17% in patients of COPD. And we have to make sure that total PEEP is included and not the PEEP which we are setting in, which means that the auto PEEP has to be calculated and taken note of. And ideally, all this should be a transpulmonary measurement rather than the airway pressure measurement, for obvious reasons that the patient's transalveolar pressures are the ones which are the culprit as far as the ventilator-induced lung injury is concerned, and they might be different than the airway pressures that we are trying to measure. So an esophageal balloon measurement of the transpulmonary pressures, and then measuring transpulmonary driving pressure is the way to go. What is the evidence? We all know that in 2015, this landmark trial from Marcelo Amato's group came in New England Journal, and that's the one which woke us up to the importance of driving pressure. This is actually a retrospective analysis of previously prospectively collected patients included in various 9 major RCTs. And these are the 4 RCTs related to low tidal volume before the ARDS networks. Very landmark study came out in 2000 related to the lower tidal volumes. And the 3 high PEEP related studies, one by the ARDS network, the alveolar trial, and the French and the Canadian trials called LOUDS and EXPRESS, which tried to compare higher PEEP versus low PEEP in trying to ventilate these patients of ARDS. And the last one was the Harvard trial of Talmer, which came out in 2008, which looked at the esophageal pressure guided adoption of the high PEEP, adjustments of high PEEP in these patients. And all these to pull together had 3,562 patients. They were then statistically analyzed to look at what their driving pressure was, rather than whether they had low tidal volumes or high tidal volumes or low PEEP or high PEEP. And the difference in their outcome was based on the analysis, was then looked at and was then correlated in relation to the driving pressure that these patients had. The analysis, it was a great deal of statistical jugglery that they had to undertake. The trial took 3 years to complete, and this analysis showed that the relative risk of death in the hospital was significantly higher with driving pressures which crossed a numerical value of 15 in the combined cohort with multivarious adjustments. So it was the driving pressure, not the tidal volume, which determined the barotrauma in all these patients and determined the mortality. So the moment the driving pressure crossed 15, the barotrauma incidence and the mortality both started going up. So the outcomes were not related to the tidal volumes low versus high or the high PEEP versus low PEEP. And in a secondary analysis, what they did was that they divided these patients into 4 quartiles, and different quartiles related very interesting observations. When these patients were divided into groups where the PEEP was kept constant, but the plateau pressures were increased, which meant that the driving pressures continued to increase. In that group, in that kind of analysis, the relative risk of death also continued to increase. So the relative risk of death was more related to higher driving pressures. And a similar analysis, but this time the plateau pressures were were allowed to remain high, but the driving pressures were kept constant, which meant that the PEEP was allowed to go up. Accordingly, the plateau pressures kept going up, but the driving pressures were maintained. And when the driving pressures were maintained, the risk of death was maintained. And inversely, when the PEEP was increased, but the plateau pressure was maintained, which meant that the driving pressure was allowed to come down, the risk of death started going down. So it's not the low versus high PEEPs or the low versus high plateau pressures which actually mattered. It was the driving pressure which correlated with the risk of death in these analyses. So it was a great study, great postulation. It was an elegant epidemiological examination of the physiology. However, unfortunately, this was a secondary reanalysis of the RCTs. And this kind of reanalysis does not equal to the importance of an RCT. This is just a post-randomization variable. And therefore, it remains an intellectual curiosity, very interesting observation, something which needs very closely to be looked at and analyzed by way of future RCTs, but by no means equal to an importance of the derivations from a prospectively designed RCT at this point of time. And therefore, the editorial at that stage strongly urged the caution at that stage and said that we shouldn't be setting our ventilators to limit our driving pressures, but we should be looking at this to erect further studies to see whether this is an elegant concept. After 2015, we started getting further evidences. The JAMA study in 2016, which looked at the epidemiology pattern of care and mortality, also showed that there was a difference in mortality between those wherein the driving pressure was less than 14 and more than 14. Chimelo's study in critical care in 2016 actually measured the lung stress and correlated driving pressure with the lung stress and said that the higher the driving pressure, the higher is the lung stress in these patients. And also, Talmer's group in Harvard also measured the transpulmonary driving pressure 24 hours down the line and came to a similar conclusion like Amato's study, where they said that the driving pressure did correlate with mortality of these patients, but a transpulmonary driving pressure of 10 or more was probably harmful rather than the airway driving pressure of 15 or more. This was the study which came out in intensive care medicine in 2016, which looked at these transpulmonary driving pressure. The reanalysis of the high PEEP versus low PEEP trials of the French and Canadian group came out recently last year. And that also showed that the changes in driving pressure were more informative about the benefit from ventilator adjustments rather than adjustments related to oxygenation. So they said that when they analyzed the previous high PEEP versus low PEEP data, they realized that the benefits were occurring because of the changes in the driving pressure rather than changes in the oxygenation, which were seen in those patients in relation to the mortality. A significant number of studies have also started looking at patients without the ARDS, and they have interestingly noted that the same concept of mortality related to higher driving pressures in ARDS does not apply to non-ARDS studies, to non-ARDS patients. So a lot of recent literature, both in chest and critical care, have come out and showed us that as far as the non-ARDS patients were concerned, probably it's the tidal volume which was more associated with with the complications and mortality in non-ARDS patients, not so much the high driving pressures as we saw in the ARDS cohort. People also started measuring intraoperative driving pressures, and these studies done in the intraoperative periods in the operating rooms showed that in the non-cardiothoracic surgery patients on mechanical ventilation, the driving pressure did present a continuous and dose-dependent relationship to the incidence of major postoperative pulmonary complication in terms of pulmonary edema, ARDS development, pneumonia, etc., etc. And a meta-analysis of studies related to protective ventilation during general anesthesia also showed that the only ventilatory parameter associated with increase in postoperative pulmonary complications was the driving pressure. All along, we've been saying that the driving pressure needs to be measured in patients who are sedated and paralyzed, but there have been some elegant studies which have looked at the ability to measure driving pressure during spontaneous breathing also. And they've showed that if you do measure them in patients who were having some spontaneous breathing effort, the negative changes in the pleural pressures become additive to the distending pressure and therefore need to be considered when you are trying to measure the driving pressure. And therefore, the actual measurement in patients who are spontaneously breathing becomes a little complicated in terms of calculations. So people have looked at studies and people have looked at data to show how during some natural spontaneous breathing or supported spontaneous breathings, we can still measure the driving pressure, but we'll need to be careful about the patient effort to be quantified. These people also showed that it can be reliably measured during the assisted ventilation with spontaneous breathing, and the outcome could be correlated with the driving pressure. So these data, which came out 2 years ago, showed that the driving pressures correlated even in patients with assisted ventilation rather than just the peak pressures. It was more the compliance and the driving pressure which correlated with the outcomes. Okay, what's the road ahead? The question that we need to ask is that does a driving pressure limited strategy improve outcomes versus traditional approaches? We need to erect now prospective randomized control trials in order to assess, answer these questions. And the first step needs to be to see whether such kind of studies are feasible. Then if they are feasible, then erect the studies to look for their efficacy. And having shown the efficacy, then we need to see whether it's effective in actual integration in practice. And the first step has already been taken last year when Amato's group, in a small study, looked at did a pilot RCT to see whether it's feasible to do the driving pressure limited strategy for patients with ARDS. And they said that yes, it is feasible. However, to do a large RCT for driving pressure driven protocol to be studied and compared with regular ventilation is a little tricky. The heterogeneous nature of ARDS and the inherent limitations of that will itself pose a problem. The continuous measurement of driving pressure is a difficult thing, and therefore we need to define times, and that may be changing in patients of ARDS from time to time. The spontaneous respiratory effort, we did talk about it some time ago. And if we are eliminating that by giving these patients neuromuscular blockade and sedation, then that itself needs to be factored into in terms of the outcomes and how long do we continue that. All these factors will need to be answered before we erect a large RCT for a driving pressure related driven protocol to be studied and compared with the regular ventilatory strategies. And therefore, right now, there are studies in the pipeline, but they have these limitations. They will be facing these difficulties, and when they come out, we'll need to assess these studies with these limitations, whether they are answered or not. So what is the current bedside utility of driving pressure to you, to we all as the bedside clinicians? If we really erect a strategy by which we set to begin with a tidal volume and then monitor the driving pressure and see if the driving pressure is above 14 or 15, then we need to ideally insert a esophageal balloon and monitor transpulmonary driving pressures. But if we can't do that, see if the plateau pressures are also high. If the plateau pressures are not high, but the driving pressures are higher than 15, then probably we need to intervene at this point of time and optimize either the PEEP or recruit the lungs or reduce the tidal volumes in order to bring down the driving pressures below 15. That's the way we probably should be ventilating. And this kind of approach was tried in this study which came out 2 years ago, in which they tried to optimize the PEEP, optimizing the PEEP on the basis of the driving pressure. So if the driving pressure was going up above 15, then they tried to optimize the PEEP. And what is optimizing the PEEP? If you try to give too much of PEEP, we know that it causes overdistension. If you go give too little PEEP, it causes atelectasis, and both ways it is not only harmful in terms of oxygenation, but in terms of ventilator-induced lung injury more than the oxygenation. So therefore, optimal PEEP has been a struggle for all of us all along. It is now possible that we will be titrating the PEEP more on the basis of minimizing the driving pressure rather than by way of oxygenation. So this kind of a prospective physiological study was published last year in respiratory care, where they had their own protocols, and based on their measurements of driving pressure, they tried to change the PEEP to see whether by causing overdistension or by reducing the PEEP in trying to allow it to collapse a little bit or reduce the overdistension, whether they were optimizing the driving pressure. And that was the time when the compliance was the best. So when they did this study, the PEEP varied quite a lot from the baseline to the final, and the driving pressure could be brought down by adjusting the PEEP in all these patients. So although small study, it was interesting to see that by adjusting the PEEPs, the driving pressure could be brought down, and the PEEP did change from the baseline when we optimized it on the basis of driving pressure. And I have a couple of cases as examples to actually discuss how to set the PEEP based on the driving pressure. But I think these kind of material is more a workshop related material. And for a plenary like this morning's probably inappropriate, and therefore I'm going to skip this for you this morning. However, the basic issue is that increasing the PEEP to a fairly high level to make sure based on the PEEP FiO2 ratio, and not adjusting it on the basis of oxygenation, but titrate it down by adjusting it to the driving pressure, seems like an interesting way of optimizing the compliance of these lungs. And therapies that change compliance will change the driving pressure for a given PEEP and tidal volume. And that would be an interesting trick which we can play in future. There are obviously some pitfalls in trying to use that, and therefore, ladies and gentlemen, the safe ventilation has been moving over the last couple of decades or so. When we started off with low tidal volume, we realized that the overstretch or the low plateau pressures were as important. Then came the idea of using high PEEPs. And overall, we realized that it's the low ventilatory power which was important. And now in 2015, the concept of low driving power has come in. And that is probably being measured as a surrogate by the driving pressure. Hopefully, over a period of time, we will have more studies which will look at the importance of setting driving pressures or using driving pressures to set our PEEPs, set our tidal volumes, and make sure that we reduce our cumulative injurious strains. So although in 2019, the formal guidelines do not recommend setting the ventilation on the basis of driving pressure, we know that in future, over a period of time, perhaps once the studies come in, we will have understood better on the role of villi. We will have also understood better that in order to titrate the energy which is being delivered to these to these patients of ARDS, utility of driving pressure will have been elucidated more, and these prospective studies in the pipeline hopefully will be able to adjust the ventilatory settings more on the concept of the reducing the overall stress and strain and overall energy to make sure that the incidence of ventilator-induced lung injury is less and the outcome of these patients is better in these patients of ARDS. Thank you very much. And I take this opportunity to invite you to the next Best of Brussels meeting, which is going to be in November 2021. Thank you very much.
Thank you, Dr. That was a really perfect evidence-based talk, and we do appreciate your valuable time and the energy you have given to us. So friends, actually these are the topics, these are the plenary sessions which actually makes this Critical Care National Congress. And the message is very clear that first thing to do is do not harm. And lot of things are needed to understand our major weapon, that is ventilator. So friends, from Pune, we fly to our national capital, New Delhi, where Dr. Rajesh Chawla, yes, it's the topic where everybody is waiting for. That is the 10 best paper in critical care in 2020. That is the last year. And it's been delivered by none other than Dr. Rajesh Chawla. Dr. Rajesh Chawla is a senior consultant in respiratory medicine and critical care medicine at Indraprasth Apollo, Delhi. And what I say, he was the past president of our own ISCCM and National College of Chest Physician. He is a national coordinator for our 4C course and critical care infectious disease course. And he was a chancellor for Indian College of Critical Care Medicine. Welcome, Dr. Rajesh Chawla. Over to you.
Please play that. Good morning. Today I'm going to discuss the 10 best papers in critical care in 2020. As you all know, the last year has been a COVID years, but there have been studies which have been published and they are of significance. The first paper which I have selected is the liberal or conservative oxygen therapy for acute respiratory distress syndrome. As you know that the ARDS study, the classical ARDS study, which was done by ARDS Network, showed that when you maintain between 55 and 80 millimeter of PaO2, it was associated with improved survival. But it has really not been validated in a prospective trial. So this was a trial which was a multi-center randomized controlled trial. Blinding was not performed, seeing the nature of the intervention. 13 ICU in France between 2016 to 18. All patients who had ARDS as per the Berlin definition were included. And in the conservative group, they maintained the target 55 to 70 millimeter of mercury, and SpO2 between ABG was maintained between 88 to 92. And in the control group, the target was 90 to 105 millimeter, and the SpO2 was maintained above 96%. And the management common to both the groups was it was ventilated as per the ARDS network. And if PO2 was not within the predefined range, the FiO2 was increased by 0.05, and similarly the SpO2 was not within the range, the FiO2 was modified by 0.05 every 5 minutes. And what they found, the death from any cause at 28 days, there was no difference in mortality. But what they found in their secondary outcome, that day 19 mortality, it was more in the conservative group as compared to the liberal group, 44 versus 30%. And mesenteric ischemic events were also more in the conservative group. And this is the summary of all other, which were rest of the things were not different. So the outcome or the conclusion from this study was the conservative oxygen strategy during the first 7 days of mechanical ventilation did not reduce mortality at 28 days, but there was a clinically relevant excess of mortality in the conservative oxygen group at day 90. And there was increased incidence of mesenteric ischemia. And the trial was stopped early because of this risk. You know, what should I do today? I think no longer you should try to maintain below 90. One should maintain SpO2 90, even if one has to give a higher FiO2, which is within the reasonable range, then you can give a higher oxygen to maintain the saturation above 90%. And this is what I think is the conclusion from this study. The next study which I have taken is a non-sedation or light sedation in critically ill mechanically ventilated patients. I think this has been a ongoing our aim that we should not give sedation, we should not paralyze, we stop paralyzing patient, and now we are thinking if we can do without sedation. So this was an investigator-initiated randomized controlled trial, was done in 8 Scandinavian ICUs, which had 1-to-1 nursing. And the patients who were more than 18 years and were going to be on ventilator for more than 24 hours were included. In the no sedation group, patient did not really receive any sedation, but they were given morphine for analgesia boluses. And the low sedation group, patient received continuous sedation, aim for RAS -2 to -3. Propofol was given for first 48 hours and then swapped to midazolam. And there was a daily sedation break each morning, aiming to get a full wakefulness in these patients. Management common to these groups for analgesia, paracetamol or morphine was given. CAM-ICU screening was done at least twice daily, and prophylactic low molecular weight heparin was given. And what they found, 90-day mortality, there was no difference in the no sedation or a light sedation. And secondary outcome also, they did not find any significant difference. But what they found was that in the no sedation group, accidental extubation were more. 31 versus 14, that is 8.9 versus 4%, clinically significant. And accidental removal of other equipment was also, as you can see, was clinically significant, 15% versus 9%, and significant decrease in the thrombotic events in the no sedation group. So my take from this is that if you maintain a light sedation, that means RAS -1 to -2, and have a daily sedation breakup where you assess the patient and avoid sedation. So I think we should avoid absolutely no sedation, but we should maintain a lighter sedation. And as soon as we can do without it, we should do that. So conclusion from this study was that among critically ill adult receiving mechanical ventilation in the ICU, mortality at 90 days did not differ significantly between those assigned to a plan of no sedation and those assigned to a plan of light sedation. Then the third study which I have selected is effect of reduced exposure to vasopressor on 90-day mortality in older critically ill patient with vasodilator hypotension. I think since the reverse study, we have been aiming for a mean arterial pressure about 65 to 90. So this was a study which was planned that people who are more than 65 years and they are admitted to the ICU with a vasodilatory hypotension, whether permissive hypotension, that is between 60 to 65, reduces mortality at 90 days. So very large studies, 65 ICUs in the UK between 2017 to 2019. Patients were more than 65 years and that had been having the vasopressor for less than 6 hours. Patients were adequately fluid resuscitated, and the vasopressor were expected to continue at least for 6 hours were included. Patient who had a contraindication to permissive hypotension or treatment for brain or spinal cord injury, in these patients, the permissive hypotension was not allowed. So what they found that the permissive hypotension group, they maintain a BP of 60 to 65, and they used all kind of vasopressor. It was at the discretion of the treating physician. And in the standard care, the mean arterial pressure targets were at the discretion of the treating ICU team. The choice of vasopressor and other treatments were at the discretion of the treating team. And as you can see, there was no significant difference between the permissive hypotension and the usual care group. Mortality at 90 days, there was no difference, and there was no difference in the secondary outcome. So the other thing they found that the reduction in mortality was more pronounced in the permissive hypotension group patients who were identified to be chronically hypertensive and tended to be greater survival the older you were. And in chronic hypertension group subgroup, 90-day mortality was 38.2 versus 44. So people who were chronic hypertension, there if you try to maintain the permissive hypotension, they had decreased mortality. And corticosteroids, fluid balance, and urine output, they were all similar between the intervention and the control arm. My take on this is that probably you should maintain a blood pressure around 65 to 70. And I think we need more study in the chronic hypertensive group for permissive hypertension to really put this into practice. The next study which I have included is the effect of vitamin C, hydrocortisone, and thiamine versus hydrocortisone alone on time alive and free of vasopressor support among patients with septic shock, the vitamins randomized clinical trial. I think last few years, there's a lot of interest on the use of vitamin C, hydrocortisone, and thiamine in patients of sepsis and septic shock, practically in septic shock. So this study was whether the patient can be off vasopressor for a longer time if you give this combination. It was a pilot multi-center randomized open label 10 intensive care unit in Australia, New Zealand, and Brazil in 2018 and 2019. The all patients who had a SOFA score more than 2, their elected level greater than 2, and the vasopressor dependence for at least 2 hours were included. The intervention arm received vitamin C 1.5 gram every 6 hours, hydrocortisone 50 milligram every 6 hours, and thiamine 200 milligram every 12 hours. And the study intervention continued until cessation of vasopressor administration or any of the other criteria for stopping the study intervention were met, like shock resolution, 10 days of vitamin C and thiamine has been administered, or 7 days of hydrocortisone, or patient dies or discharged. And in the control group received IV hydrocortisone 50 milligram every 6 hourly, and thiamine was administered at the discretion of the treating physicians. Control group received the, as I said, IV hydrocortisone and thiamine at the discretion of the attending physician. And as you can see, there was not much difference in both the groups, and the vasopressor used during first days, not much difference between both the groups. So there was no difference in mortality, There was no difference in the primary outcome, free of vasopressor up to day 7. And in the secondary outcome, there was absolutely no difference. So in patient with septic shock, treatment with intravenous vitamin C hydrocortisone and thiamine compared with intravenous hydrocortisone alone did not significantly improve the duration of time alive and free of vasopressor administration over 7 days. The findings have shown that this does not lead to more rapid resolution of septic shock compared with intravenous hydrocortisone alone. So had what is called the hydrocortisone, the vitamin C and the thiamine, I think now we can pay rest to this. Probably there are a few more studies which are ongoing, which will also give us answer, but probably this combination has not been proven to be effective in decreasing the vasopressor requirement or off vasopressor early in patient of septic shock. The next study which I'm going to discuss is the timing of initiation of renal replacement therapy in acute kidney injury. You know, this is always, there have been few trials which have again discussed early renal replacement therapy versus the late replacement therapy. The rationale for delaying dialysis or giving early dialysis is that if you give an early dialysis, it achieves optimum fluid balance via ultrafiltration. You remove the toxic solutes and may mitigate the inflammatory milieu and correct the metabolic acidosis. And for delaying dialysis is that you lack the procedural related risk to the patients are less. You avoid unnecessary intervention and it saves the resources. So the START AKI trial, standard versus accelerated initiation of renal replacement therapy, it was an open label randomized controlled trial, multi-center, and patients who were included who were more than 18 years. AKI was defined when the creatinine was more than 1.13 in women and more than 1.47 milligram per deciliter in men. Evidence of severe AKI was taken when at least one of the following criteria were present: more than twofold increase in creatinine from the baseline, or creatinine more than 4 milligram per deciliter and 0.3 milligram per deciliter above the baseline creatinine, or urine output is less than 6 ml in the last 12 hours. Patient were randomized to accelerated arm, needed to commence the CRRT within 12 hours of randomization. 96.8% received dialysis and the average time to commencement was 6 hours. In the control arm, patient was discouraged for RRT unless there is a persistent AKI or creatinine has risen more than 50% from the value which was recorded at randomization, or patient has one or more of the classical indications like potassium more than 6, pH less than 7.2, bicarb less than 12, fluid overload, or the persistent AKI for more than 72 hours from the randomization. 61.8% of the patient received dialysis. The management was, rest of the management was common to both the groups. As you can see, absolutely no difference in survival at 90 days between both the groups. There were a lot of strength, their allocation concealment, intention to treat analysis, blinding of outcome assessors, near complete follow-up. Patient were analyzed by the group they were allocated to. The weakness was that equipoise was difficult to define because who were excluded because the treating physician felt accelerated or delayed RRT was mandated. The primary outcome, 90-day mortality, was no significant difference, and secondary outcome also there was no significant difference in the day 90. So this study concluded that critically ill patient with severe acute kidney injury, an accelerated strategy for initiation of renal replacement therapy did not result in a lower mortality at 90 days than a standard therapy. The next study which I'm going to include is the classical, which all of you must have read and heard many times. That is the recovery trial, dexamethasone in hospitalized patient of COVID-19. This is the only study from COVID I have included in these 10 papers. It included SARS-CoV-2 patients, and they were given steroid versus the standard care. The people who were included suffering from SARS-CoV infection, age more than 18 years, and patients were permitted to be included even if they were pregnant or breastfeeding. When there was a contraindication to dexamethasone, they were excluded, and or the dexamethasone was unavailable at the time of randomization. Only these two groups were excluded. They gave 6 milligram daily of dexamethasone for 10 days, intravenous or oral. In pregnant or breastfeeding women, prednisolone 40 milligram was administered, or intravenous hydrocortisone 80 milligram twice a day. And control patient was given the usual care. There were more patients in the usual care, 2,500 odd patients and 1141 patients in the dexamethasone group. And what they found was that mortality at 28 days was less in the dexamethasone group as compared to the usual care, 22.9% compared to 25.7% in the usual care. As you can see, there was a difference. If all participants were included, there was a significant difference. There was a difference, as you can see on the right-hand corner, that if patient was in invasive mechanical ventilation, there was a significant difference in mortality. There was a decrease in mortality in the dexamethasone. Similarly, patient on oxygen, there was a decrease in mortality, but there was no decrease in mortality. Rather, there was increase if there was no oxygen. So patient who are on oxygen, as you can see, forest plot also, the patient who are not on oxygen, the usual care was better as compared to the dexamethasone. So in patient hospitalized with COVID-19, the use of dexamethasone resulted in a lower 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen alone at randomization, but not among those receiving no respiratory support. Then, when there are few patients in the ICU who become dependent on vasopressors, and small amount of vasopressor continues and it leads to increased stay in the ICU. So this was a MIDAS trial, which was to effect of midodrine versus placebo on time to vasopressor discontinuation in patient with persistent hypertension in the ICUs. Midodrine is an oral alpha-1 adrenergic agonist. So there have been no randomized trial to study the use of midodrine in this setting. Multi-center randomized trial 1:1 ratio using computer. The patient included were more than 18 years. Single agent who had a single agent at the time of randomization could be a phenylephrine less than 100 mics per minute, or norepinephrine less than 8 mics per minute, or metamironol less than 60 microgram per minute. Patient had to be resuscitated and reversible cause of hypotension had been treated. In the intervention group, midodrine was given 20 milligram 8 hourly, and placebo was given 8 hourly in the match control group. Then the rest of the treatment was similar in both the groups, and they did not find much difference. The median time from study drug initiation until discontinuation of IV vasopressor, there was no difference in the midodrine group compared to the placebo group. And secondary outcome also, length of stay, discharge, hospital length of stay, there was no difference. There were a lot of strength. This was a randomized, double-blind, multi-site. The inclusion criteria of a low dose, single vasopressor use seemed sensible, but weakness was did not specify the weight-based dose, mean fluid balance, 100 ml higher in midodrine group, and they took about 7 years from this study. This is period is too long and the lot of changes in the usual management. So these were the weakness. But the another thing which they found was in post hoc analysis in patient with epidural analgesia, there was a significant reduce in midodrine group as compared to the placebo group. So they were able to remove vasopressor early in patient who were on epidural analgesia. So my take on this is midodrine has not been proven in this study, probably not of much efficacy, but I think in epidural analgesia we need more study to put into practice. So the use of midodrine did not result in earlier liberation from vasopressor in critically adult when compared to placebo as far as this study is concerned. The next study which I'm going to discuss is timing of endoscopy for acute upper gastrointestinal bleeding. You know, there is always a hurry when a person develops an upper GI bleed to get up endoscopy early. So this was a study for acute upper GI bleed within 24 hours by an international consensus group. And the GBS, which is the Glasgow Blatchford score, assesses whether a patient with an acute upper GI bleed will require a medical intervention. So where score was more than 7 has the greatest need of intervention, and typically a score of less than has a minimal risk. So this study randomized computer generated sequence, and they were analyzed on intention to treat more than 18 years old who had upper GI bleed, comparatively stable patients, the GBS score more than 12, the urgent endoscopy within 6 hours of gastroenterology consultation, or they had a mean time of 2.5 hours post gastroenterology consultation and 9.9 hours after the initial presentation. And the control group or the early endoscopy between 6 to 12 hours of gastroenterology consultation. If patient was seen between 12 and 8 a.m., he would get an endoscopy within more than 6 hours, that is between morning. And if seen between 8 to 11:59 p.m., would undergo endoscopy the next morning. The rest of the management was common. The PPI infusion was given. If there were varicose bleed, they were all clipped like a usual practice. And this was the outcome in both the group. They did not find much difference in the cumulative probability of death or bleeding in both the group, the urgent as well as the early endoscopy. So all-cause mortality at 30 days, there was no significant difference between the urgent endoscopy group or the early group. The secondary outcome also, the endoscopic treatment during initial endoscopy was significantly greater in the urgent group as compared to the late group. And there was no significant difference in further bleeding within 30 days. So this study concluded the endoscopy performed within 6 hours of gastroenterology consultation rather than 6 to 24 hours did not reduce 30-day mortality. So basically, there is no the urgency to rush for endoscopy. The only other thing which is in this study was that in patient with high risk upper GI bleeding who were treated with pre-endoscopy PPI and were not in persistent shock, an endoscopy performed at median of 10 hours versus a median of 24 hours post-presentation did not reduce 30 days mortality. This is just to further see in the weakness of this study was the comparatively stable patients. Practically the kind of patients we get in the ICU are unstable patients. But I think still there is no rush to get an endoscopy within 6 hours unless the patient is quite unstable. Then the next study which I am going to discuss is the viscoelastic hemostatic assay augmented protocol for a major trauma hemorrhage randomized controlled trial. You know, viscoelastic hemostatic assay management is increasing. We are using TEG and ROTEM are the most commonly used assay out of these, and they allow rapid point of care monitoring. Whole blood is tested and real-time graphical presentation of patient coagulation state is created. And 2016 Cochrane review said that the TEG or ROTEM guided transfusion strategy may reduce the need of blood product and improve mortality. And the 5th edition of European guidelines have also said that the viscoelastic hemostatic assay or the CCT can be used for the early and repeated monitoring of hemostatic. But this has not been really tested in a randomized controlled trial. So this was a multi-center randomized controlled trial, compared outcome in patient receiving an empiric major hemorrhagic protocol, MHP, supplemented by the viscoelastic hemostatic assay by either VHA or by CCT, conventional coagulation test. Either one group went the viscoelastic hemostatic assay based supplementation, the other conventional coagulation test based, randomized 1-to-1. And the 7 major centers, all they were adult trauma patients. The clinical signs of bleeding, their local MHP activation and packed red blood cell transfusion were initiated within 3 hours of injury and 1 hour after the admission to the emergency department. In the intervention group, viscoelastic hemostatic assay was used, clear parameter given for blood product replacement for both ROTEM and the TEG readings. VHA tests were performed at point of care and parameter acted upon, and in the other conventional coagulation test, clear parameters for a given blood product replacement was done accordingly. The rest of it was common, all received blood product in 1:1:1, PRBC, platelet and plasma. Limited crystallized were administered in both the groups. And massive transfusion was defined when you require more than 10 units of PRBC. And they did not find any difference whether you do a resuscitation based on the viscoelastic assay or you do according to the conventional coagulation test. At 24 hours, there was no significant difference, 67% versus 64%, no significant difference in outcome in the secondary. So this study concluded that VHA augmented MHP testing did not improve the overall outcomes when compared to the conventional coagulation test augmented the MHP. You know, I think we are practicing now VHV, TEG and ROTEM. They are being used in point of care. I think we require more studies to really put rest to this theory that they are both equal. The last study which I'm going to discuss is a trial of dexamethasone for chronic subdural hematoma. You know, these patients do present in the neurology department with altered mentation, and the reason could be cerebral atrophy, and these patients could be on the anticoagulants, or there could be minor head trauma. This is the 3 reasons that why the chronic subdural hematoma these patients present. The management of chronic subdural hematoma usually includes the clot evacuations, if there is evidence of neurological deterioration, or if the clot is more than 10 millimeter or is causing midline shift. In this study, there was a randomized controlled trial, 1:1 randomization of a 14-day tapering course of dexamethasone. And the patients were more than 18 years with a symptomatic chronic subdural hematoma seen as a hypodense or isodense crescentic collection on the CT. Dexamethasone 2-week course was given oral and then tapered off, and the control was matched placebo. And as you can see, the modified Rankin score was better at 6 months. And if you see the 0, 1, 2, 3, they were better at 6 months in the placebo group as compared to the dexamethasone. Significantly better outcomes in the placebo as compared to the dexamethasone. Similarly, the secondary outcomes was significantly better in the control group. MRS 0 to 3 at 3 months and mortality at 3 months was also better in the placebo group. That means mortality was less. So in patient with symptomatic chronic subdural hematoma, treatment with dexamethasone resulted in a fewer favorable outcomes and more adverse events compared with placebo. However, recurrence of the subdural hematoma requires repeat surgery was less likely in the dexamethasone group. So my take on this is that probably we should not be using dexamethasone in the chronic subdural hematoma. So if I see, these were the 10 studies which I had selected. So most of these studies have been negative studies. And the one study which really changed the outcome in COVID-19 was the dexamethasone recovery trial. Thank you very much.
Dr. Rajesh Chala, that was really an energetic talk, and we appreciate your time for this. And I'm pretty sure that this has cleared a lot of hypes that has been raised among a couple of years back. About this session, I would simply say, wow, it was a mind-blowing session. And these are the sessions which make this National Congress. And friends, we end this session, but don't go anywhere because lot of gems are hidden. Lot of gems are being hidden in this National Congress and in a quest to find to deliver the perfect critical care to our patients. Thank you everyone for staying with us.
Yeah.
And
thank you, Dr. Tejas. Thank you for your moderation. We will move on to the next session with the limitation of time. This is a free paper session, and we have around 10 papers. And to evaluate this, I invite Dr. Ghanshyam, who is the head of the department and the director for critical care medicine in Medicover Hospital, Hyderabad. He's also a part of the National Executive Committee for the last 3 years and is a prominent part of the critical care medicine and ISCCM in Hyderabad. I invite Dr. Ghanshyam, over to you.
Thank you, Venkat. As you said, let us move ahead because we are short of time. And free paper sessions, I congratulate all the presenters who have done the work and have come here to present their experience. It's good to see so many free papers being presented in the national conference. My best wishes to all of them. So let us go ahead. The first paper is by Dr. Anand Kumar Singh. Can we have the intro slide? He is going to present his paper on the transport of critically ill patients, which is always a very, very big challenge. As you know that things can really go awkward and out of hand when we're transporting sick patients out of the intensive care unit for either a procedure or for imaging, etc. Dr. Anand Kumar Singh.
Good morning to everyone. Myself, Dr. Anand Singh, trainee resident in Department of Critical Care Medicine, SDPJ, Lucknow. Topic for my presentation is intra-hospital transport of critically ill patient, experience from a tertiary care teaching hospital. Introduction. Transport of critically ill patient is necessary for optimal patient care. Our department has well-established protocol for transport of critically ill patient, accompanied by a nurse and a trainee doctor, resident doctor, and necessary equipments. Objective to the study is to study the demographic of critically ill patient requiring transports, number of transports for each patient, duration of transport, number and type of adverse events occurring during intra-hospital transport of critically ill adults, factors affecting these adverse events, outcome of transport in terms of change and benefit in patient management. Methodology. The inclusion criteria: critically ill patient more than 18 years old transported to radiology department. The prospective study was conducted in mixed ICU of Tertiary Care Teaching Institute from May 2019 to June 2020. And the data collected includes demographic, vital parameters, adverse events and intervention provided, outcome, duration and number of transports, organ failures and organ support during transport. Statistical analysis. Descriptive statistics for demographic data and ANOVA for factors associated with complications. And SPSS 20 was used for statistical analysis. Demographics and admission status. Out of 104 patients included in the study, they were transported 152 times. 20 patients had single organ failure. 29 patients had 2 organ failure, and 54 patients had more than 3 organ failures. In organ supports, including mechanical ventilation in 92 patients, vasopressor support in 68 patients, renal replacement therapy in 38 patients. And number of transports done in 28 days, 67 patients required 1 transport, 26 patients required 2 transport, and 11 patients required 3 or more transport. And most common diagnosis involves CNS pathologies in 31 patients, and acute pancreatitis in 29 patients, and others 64. And median age was 49 years old, and 66 were male. And median admission so far was 10, and Apache was 24, and median length of ICU stay was 40 days. Details of transportation. Out of 152 transports, the most common transport destination was CT scan in 107 transportations, MRI in 30 transportations, and others in 15. The median so far on transport day was 14. The median duration of transport was 32.5 minutes. Supports during transports were respiratory supports used during transportation were mechanical ventilation in 110 transports, oxygen support in 40, and room air in 12. And vasopressor supports were used in 75 transportations, and median VIS was 5. And bolus addition were given in 59 transportations. Significant changes in vital parameters during transports were noted in 50% transport had change in heart rate, 32% transportation had change in mean arterial pressure, 22% of transports had change in SpO2, 28% of the transport had change in VIS, and 10% of the transportation had change in PCO2. Comparison of adverse events and baseline characteristics. The adverse events were defined as serious, associated with hypotension and desaturation, mild, associated with vomiting, restlessness, and agitation. And the pre-transport variables were compared in transport associated with serious adverse events and transportation with no adverse events. We found that the transportation associated with serious adverse event had a higher mean heart rate, low mean arterial pressure, and higher VIS score when compared to transportation associated with no adverse events. There is no significant change in SpO2, FiO2, SOFA score, or duration of transportation in minutes. Duration of transport did not affect these adverse events. Vital parameter change during transportation did not affect the adverse events. Outcomes, the diagnostic benefits were found in 150 transportation and therapeutic benefit in 140. Coming to conclusion, the safe intra-hospital transport of high-risk critically ill patient is possible when accompanying resident doctor and nurses are well trained. And significant change in heart rate, mean arterial pressure, and VIS score was found in transports associated with adverse events. Thank you.
Thank you, Dr. Anand. Because we are running short on time, we will skip the question and answer sessions. We'll move to the next free paper presentation. Dr. Nishant Agrawal, who is going to present his experience about the experimental chest X-ray scoring system for determining patient outcomes in COVID-19. Dr. Nishant is a senior resident in the Department of Critical Care from Vidyapit Medical College Hospital, Pune, Maharashtra.
Good morning, one and all. I am Dr. Nishant Agrawal, senior resident in the Department of Critical Care Medicine, Bharati Vidyapit, deemed to be University Medical College and Hospital, Pune. And the topic of my oral paper is experimental chest X-ray scoring system for determining patient outcomes in COVID patients. To start with, we all know chest CT is considered as the most effective method of quantitative assessment of severity and the progression of COVID-19 infection. Chest X-ray can be used as a diagnostic tool for monitoring the rapid progression of lung abnormalities in infected patients, particularly in intensive care unit. To improve the risk stratification for infected patients, a chest X-ray scoring system has been developed for quantifying and monitoring the severity of lung abnormalities in patients with COVID-19, named the Brixia score, grades the lung abnormalities due to COVID-19 on an 18-point severity scale. Our study aimed at comparing the novel chest X-ray severity score that is scored by an experienced radiologist with the outcome in ICU patients with moderate to severe COVID-19 pneumonia, that is, with those patients with maintaining a saturation of less than 94%. And the objective of our study is to determine the validity of chest X-ray scoring system in measuring the outcome for patients infected with COVID-19. Materials and methods. Now, this was a retrospective study which was carried out over a period of 4 months, from 1st of April to 31st of July in our institution, and all consecutive COVID positive patients admitted to ICU and who were requiring oxygen in any form, in the form of HFNC, NIV, or invasive ventilation, or a non-rebreathing mask with 50 liters of oxygen were included in our study, whereas patients with chronic organ failure and chronic neurological illnesses were excluded from the study. On admission, the patient's detailed history was taken and examination was carried out. Their baseline X-rays was scored by a radiologist who was blinded to the final outcome of the patient as well as the demographic details of the patient. Now, the validity of the scoring done was evaluated against the two outcomes of the patient in form of discharge or death. The gender of the patient was correlated with his or her outcome. Now, this is how we have actually done our test X-ray scoring. The test X-ray scoring system used for COVID-19 pneumonia includes two steps of imaging analysis. Basically, there are two vertical lines which have divided the lungs into 6 zones. The upper zones A and D, which are present above the inferior wall of the aortic arch. The middle zones B and E, which are present below the inferior wall of the aortic arch and above the inferior wall of the right inferior pulmonary vein. And the lower zones, that is the C and F, which are present below the inferior wall of the right inferior pulmonary vein. In the next step, we had now designated a score of 0 to 3 to each of these zones based on the lung abnormalities detected on the frontal chest projection. Score 0 was given for no lung abnormality. Score 1 was given for interstitial infiltrates, 2 for interstitial and alveolar infiltrates with interstitial predominance, and score 3 is similar to score 2 but with alveolar predominance. And the total score was ranging between 0 to 18. Now, if you see the results, the total sample size in our study was 130, and we had actually done a statistical analysis with SPSS software version 25.0. Results of the categorical variables were done based on the chi-square test, whereas independent t-test was used for the other continuous variable with normal distribution. And the p-value of 0.0 less than 0.05 was considered to be significant. Now, among the 130 patients whom we had included for the study, we can see that 79 died, whereas 51 got discharged, with minimum age being 30, maximum being 95. Amongst the discharge, it was minimum being 18, maximum being 75. In the chest X-ray score, amongst the death individuals, the minimum chest X-ray score was 5, whereas the maximum was 17. Whereas amongst the patient who got discharged, the minimum chest X-ray score was 6, the maximum being 16. Now, when we compared the chest X-ray score to the final outcome in terms of death or discharge, we found that the p-value was statistically significant. It was less than 0.03, which is less than 0.05. In our study, 70.8% of the patients were included by males and the rest were females, and there was no correlation between the gender of the patient and the final outcome in terms of discharge and death. The p-value was 0.22, which is not statistically significant. Now, to conclude, our study conferred that high BRIXIA score was associated with a high risk of death due to COVID-19, and we contemplate the scoring system to be very apt as it provides very clear and to the point information for clinicians in this prolonged battle against COVID-19. These were my references. Thank you.
Thank you, Dr. Nishant. Hello?
Yeah, go ahead.
Yes, you're audible. Yeah. Thank you, Dr. Nishant. Thank you very much for the wonderful presentation on the usefulness of chest X-ray. Because many of the centers may not have the facility for doing CT scans very regularly. Moving on to the next paper by Dr. Tushar Kumar, who is going to present his experience on the comparison of early BIS index guided post-operative extubation versus extubation in awake patients in neuro-intensive care unit. Dr. Tushar Kumar is from the Rajendra Institute of Medical Sciences, Ranchi. Dr. Tushar.
Good morning, sir. My name is Dr. Tushar. I'm assistant professor in the Department of Anesthesiology and the Rajendra Institute of Medical Sciences, Ranchi. The topic of my presentation is comparison of early bispectral index guided post-operative extubation versus extubation in awake patients in neurointensive care unit. The aims and objective of our study is the aim is to evaluate the safety and effectiveness of bispectral index guided early extubation in neurosurgical patients during anesthesia recovery period. The primary objective is to compare the bispectral index guided postoperative extubation versus extubation in awake patients using Richmond agitation sedation score and behavioral pain scale in neuro ICU after craniotomy and excision of supratentorial space occupying lesions. Null hypothesis is that there is no difference in outcome of extubation between scoring system and BIS guided extubation. Alpha error was 0.05 and confidence interval was 95% with p-value of less than 0.05 as significance. The total sample size in our study was 16, that is divided into two equal groups. Group B considered bispectral index groups and group S considered sedation group. Patients were received in neuro ICU with endotracheal tube in situ following craniotomy and craniotomy for space occupying lesions who required ventilatory supports. Sedation was commenced with fentanyl and midazolam infusion, that is the protocol of our institution, and the infusion was titrated to keep the patient comfortable on ventilator. All the patients were evaluated next day after 2 hours of sedation with either by bispectral index monitoring or Richmond agitation sedation score, along with behavioral pain scale. Oxygen saturation by pulse oximeter, heart rate and mean arterial pressure were recorded before extubation, that is at time t0, 1 minute after extubation, that is time t1, and 5 minutes after extubation, that is time t5. The observation and results were collected. The data was collected for pulse rate and mean arterial pressure was tested by Pearson correlation coefficient for significance, and the data for data of oxygen saturation and behavioral pain scale was tested by Kruskal-Wallis test. The pulse rate and mean arterial pressure, both the data was p-value was insignificant, and oxygen saturation also came out to be insignificant, but behavioral pain scale in group B gave significant results. At T1 and T5, there were no differences in the pulse rate, the mean arterial pressure, and oxygen saturations. So in the results, we can say that mean arterial pressure and oxygen saturation were found to be non-significant. Behavioral pain scale before extubation was the only parameter in our study which was significant, which means patients were more comfortable when they are in mild to moderate sedation and are not disturbed for clinical examination. After extubation, all the parameters were yielded insignificant results. So to conclude, we can say that bispectral index monitoring for extubation after neurosurgery showed no difference when compared with Richmond agitation sedation score, that is the clinical examination, except patients were more comfortable when they are not stimulated for examination. So we can say that bispectral index patients are more comfortable for extubation, and that is for monitoring before extubation, after especially after neuro surgery for the large supratentorial space occupying lesions. Thank you, sir.
Unmute yourself, Dr. Sir.
Yeah. Thank you, Dr. Tushar. The next paper is by Dr. Surabhi Gupta, who is presenting her on the CMAC video laryngoscopy versus direct laryngoscopy, comparing the mouth to nose distance between the patient and the laryngoscopist. Dr. Surabhi Gupta is from the Department of Anesthesiology, KLE Academy of Higher Education and Research, Belagavi.
I'm Dr. Surabhi Gupta, a postgraduate student at the Department of Anesthesiology, Jawaharlal Nehru Medical College, KLE Academy of Higher Education and Research, Belgaum. The title of my research paper is CMAC video laryngoscopy versus direct laryngoscopy, comparing the mouth to nose distance between the patient and the laryngoscopist. Coming to the introduction, tracheal intubation is a high-risk procedure for the transmission of the virus during this COVID-19 pandemic. These patients may often require tracheal intubation and mechanical ventilation due to either the illness or for various emergency or elective surgeries. Procedures involving securing and manipulation of the airway may put the laryngoscopist at the great risk of exposure to the virally contaminated aerosols, thus increasing the distance of the laryngoscopist's face from the patient, and the expelled droplets reduces the direct exposure to the mucous membrane. This study aimed to determine the mouth-to-nose distance between the patient and the laryngoscopist, the angle formed between the two oral cavities, and the ease of intubation. In the methodology, the study was approved by the Institutional Ethical Committee, and 104 ASA 1 and 2 patients undergoing surgery under general anesthesia were enrolled and consent was taken. They were randomly divided into 2 groups, wherein Group A underwent tracheal intubation with CMAC video laryngoscope, and Group B underwent intubation with Macintosh direct laryngoscope. The intubation procedure was filmed, and the mouth-to-nose distance formed between the patient and the laryngoscopist, as well as the angle formed between the 2 oral cavities, were assessed using a mobile phone application. The ease of intubation was determined. Descriptive statistics reported using mean, median, and standard deviation for continuous variables and compared using students' paired t-test. Categorical variables reported using numbers and percentages and compared using the chi-square test. The results: the mean mouth-to-nose distance between the patient and the laryngoscopist using CMAC video laryngoscope was 45.56 centimeters, and using the direct laryngoscope was 27.67 centimeters. This was statistically significant using a paired t-test. The mean angle formed between the 2 oral cavities were 49 degrees and 34 degrees with the CMAC video laryngoscope and direct laryngoscope respectively. The ease of intubation was also scored more with the CMAC video laryngoscope compared to the direct laryngoscope. Here are 2 pictures showing intubation with in group A and B. Coming to the discussion, the greatest viral load of this virus is commonly found in the sputum and the upper airway secretions. Droplet spread and direct contact with the respiratory secretions is one of the most leading methods of transmission of the virus, whereas aerosol spread is another mode of transmission of these viral particles, as they remain suspended in the air for a longer period of time. Thus, procedures that involve endotracheal intubation, extubation, bronchoscopy, tracheal suctioning may cause aerosolization of these viral particles and transmission of the virus. So the study showed that the use of the video laryngoscope significantly extended the mouth-to-nose distance between the patient and the laryngoscopist, and it also placed the laryngoscopist's face at above the direct line of sight of the pharynx, thus minimizing the risk of exposure to the virally contaminated particles. It may also help to reduce the time taken for intubation, thus avoiding a longer exposure time to the laryngoscopist. In the conclusion, the video laryngoscopy thus significantly increases the mouth-to-nose distance between the patient and the laryngoscopist compared to the direct laryngoscopy, and it also increases the angle formed between the face of the laryngoscopist and the patient's oral cavity. And also, intubation is easier with video laryngoscopy compared to direct laryngoscopy, providing a better glottic view. Hence, this study signifies the use of a video laryngoscope to minimize the risk of exposure to the infected viral particles to the laryngoscopist. Here are the references. Thank you.
Thank you, Dr. Surabhi. I think that was a very novel aspect of looking at how to decrease the risk of aerosol risk to the patient who to the doctor who is intubating the patient, and that was one of the major.
The camera is off.
The whole, okay, Venkat, I think they are going to stop the videos because it's overlapping with the presentations.
Okay, go ahead.
I think that should be okay. Fine.
Sir, actually, when we play video, that time when we are talking, then we kind of.
That's fine. That's okay. That's okay. Avinash, let it be like this.
Okay, okay, sir.
Okay. Thank you, Dr. Surabhi. We will move on to the next paper by Dr. Mukund Kumar V. Patel, who is going to present on the significance of horizontal ST segment with sharp STT angle, the electrocardiographic significance sign in acute coronary syndrome. Dr. Mukund Kumar is an associate professor of medicine from Zydus Medical College and Hospital, Gujarat.
I am Dr. Mukund Kun Kumar V. Patel, Associate Professor of Medicine at Jadis Medical College and Hospital, Daud. I am presenting abstract 171, Criticare 2021. My topic is significance of electrocardiographic sign, horizontal ST segment with sharp STT angle in patients of acute coronary syndrome. We all know ECG is an integral part of clinical examination in chest pain trials, and it is to be evaluated within 10 minutes of admission. These acute coronary syndromes are classified as ST elevation myocardial infarction, non-ST elevation myocardial infarction, and unstable angina as per ECG findings and by measuring serial troponin levels. ST segment depression of more than 1 mm and T wave inversion of more than 1 mm in two contiguous anatomical lifts are well-known ECG signs for myocardial ischemia in patients of acute coronary syndromes. However, substantial number of patients have normal ECG. Our aim of the present study was to evaluate this. Normal ST segment is somewhat curved, less than 1 mm, and STT angle is obtuse. But when this ST segment become horizontal, just like a line, and STT angle become acute, then it's a subtle sign of myocardial ischemia. So this is the sign, and in our presentation it will be described as HST-STA sign. Our aim was to evaluate diagnostic value of this novel HST-STA sign in patients of acute coronary syndrome. This observational prospective study was conducted among patients above 21 years who presented with chest pain suggestive of acute coronary syndrome. Patients having ST elevation, infarction, LVBP like secondary STT deviation causes were excluded from the study. Patient who has not undergone for coronary angiogram within 4 to 6 weeks of chest pain were also excluded from the study. 12-lead ECG was recorded on admission and after 12 hours or during the reappearance of chest pain. According to ECG, patients were classified into 3 groups. Group 1 consists of ST depression of more than 1 mm. Group 2 consists of T wave inversion of more than 1 mm in at least 2 leads, and rest of the patient having apparently normal ECG were classified as group 3 patients. Group 3 cases were further classified into HST-STA positive and HST-STA negative according to presence or absence of the signs. Serum troponin was measured as per the standard guidelines. Out of 1,221 suspected ACS patients, after exclusion and follow-up patient lost, 699 patients completed the study. Mean age was 48.2 years. Frequency of ACS was 230 in group 1, 105 in group 2, and 364 in group 3. Accordingly, ACS were classified as non-ST segment elevation myocardial infarction, group 1 151, group 2 70, and group 3 221. Unstable angina, group 1 45, group 2 19, and group 2 67. And non-coronary type of chest pain in group 1 34, group 2 16, and group 3 76. This slide shows sensitivity and specificity of ST segment depression, T wave inversion, combined ST segment depression and T wave inversion, and HST-STA. HST-STA sign was more sensitive than T inversion and ST depression plus T inversion with significant p-value, and it was more specific than ST depression and ST depression plus T inversion for detecting myocardial ischemia with significant p-value. Multivariate logistic regression analysis showed HST-STA added diagnostic value over other ECG signs. In conclusion, HST-STA is an unexplored subtle ECG sign for the detection of myocardial ischemia in addition to ST depression and T inversion. Thank you for the patient hearing.
Thank you, Dr. Kumud. I think we will go to the next talk by Akash Soni. Can we have Dr. Akash Soni slides on board?
Everyone, this is Akash. I'm a respiratory therapist working in SL Raheja Hospital, Mumbai. Today I'm here to present my study titled it's a study of the COVID-19 lung, where we see the recoverability by using esophageal manometer and functional residual capacity. So as we all know that there is a very high mortality in the COVID-19 related ARDS. And the theory are regarding to bound one with low compliance and one with high compliance. And the treatments are directed accordingly, which includes prone ventilations, lung protective ventilation strategies. However, most of the studies were based on with the Western literature with the static measurements, and none of the studies talk about the actual measurements of the lung recoverability. So I think we might be the first one to talk about the recoverability of the patient's lung in COVID-19. So our objective here is to study the lung characteristics to assess the recoverability with esophageal manometry, with the measurement of the transpulmonary pressures and end expiratory lung volumes after the transpulmonary pressure guided recruitment. So this was an observational study where we have studied 88 patients during the course of 3 months from July 2020 to September 2020. And we have chosen the patients who were intubated and mechanically ventilated, where the effort intolerance where there was effort intolerance and the PF ratios were less than 150. We have also chosen those patients particularly where we have intervened the esophageal manometer. So esophageal manometry was done with the Nutrivent catheter, and the end expiratory lung volumes were measured and FRC were calculated, which we have done with the help of the GE ventilator by using the nitrogen washout technique. So we have, as I said, we have only taken the COVID-19 patients who were admitted in the intensive care unit and who were mechanically ventilated. So what have we observed and what have we found? These patients we have related to a lot of parameters. So we have related all these things with the patients whom we have prone. Okay, those patients whom we intervened with the esophageal manometer and the city severity score, the Apache score, the SOFA score. So if you see that out of 88 patients, we have intubated 69 patients. Where we have prone 37 patients and we have not prone 32 patients. And out of those 16 patients, we have only taken 30 patients, since we have intervened the esophageal manometer in only 30 patients. So around 43% of the patients who were intubated were only intervened with the esophageal manometer. And the Apache score and the SOFA score, out of those 30 patients, since 2 patients expired within 24 hours. So technically, out of 28 patients Apache score what we measured, we found that 15 patients of 15 patients out of 28 were recruitable. So as per the previous study, which we all have seen mostly in the non-COVID ARDS and in the critically ill patients, which were not very conclusive for the efficacy of the transpulmonary pressure guided recruitment, and mostly the transpulmonary pressure guided were only used for the ventilatory strategies, especially in deciding the ventilatory parameters. So as per the theory on COVID-19 lung, which was mentioned, there were 2 types of mainly low compliance and high compliance, and the strategies based on that does not really guide us about the treatment of the COVID-19 patients. So in our study, we have found that there was a significant number of the patients who were recruitable, even despite of having low compliance to start with. Therefore, the lung protective strategies, along with the transpulmonary pressure measurements, is more likely to have better recruitment of the lungs in COVID-19 ARDS patients. Thank you.
Yeah, thank you, Dr. Akash. So We will go to the next speaker, Dr. Raman Kumar. Can I have a slide of Dr. Raman Kumar? Yeah, so he will be presenting on high flow nasal oxygen therapy in COVID-19 critically ill patient with acute hypoxemic respiratory failure, a prospective observational study, and he is a part of the critical care medicine in Rajendra Institute, Ranchi, Jharkhand. So we will invite Dr. Raman Kumar for that. Dr. Raman Kumar.
Good evening to everyone. I am Dr. Aman Kumar. I am doing PTCC in Critical Care Medicine in RIMS Ranchi. I am presenting here a prospective observational study with title Impact of High Flow Nasal Oxygen Therapy in COVID-19 Critically Ill Patient with Acute Hypoxemic Respiratory Failure. Incidence of COVID-19 ARDS in ICU patient is reported to be very high. Once the patient is intubated, we have high risk of complication and mortality. But we have limited studies to determine the impact of hyperoxygen therapy in hypoxemic respiratory failure with COVID-19 critical illness. So we plan this research to determine the impact of hyperoxygen therapy on oxygenation in COVID-19 critically ill patient. Our primary objective was to determine the change in PF ratio from baseline to at 1 hour, 6 hours, 7 days, and 14 days of high flow oxygen therapy initiation in COVID-19 critically ill patient presenting with acute hypoxemic respiratory failure. After taking IEC approval and written informed consent from patient or any authorized representative, we started this study. Our inclusion criteria were adult patient more than 18 years with confirmed COVID-19 positive status with PF ratio less than 300 or inability to maintain saturation above 90% on a standard oxygen therapy. High flow oxygen therapy failure means the patient either switched to an IV support or patients were intubated. On high flow oxygen therapy device, initial flow was 50 to 60 liters per minute and 5 to 100% respectively. Using SPSS software version, we used a student t-test, peer t-test, and fragment test. Coming to results, 265 patients were screened for eligibility. Out of them, 256 had acute hypoxemic respiratory failure. Finally, 108 patients were found eligible for the study. And out of them, 80 patients they were continued on high flow oxygen therapy, means they came in success group. And in failure group, 28 patients were there, means 22 patients they switched to an IV support or 6 patients were intubated. We observed demographic variables, vitals, blood test results, and clinical outcome between success and failure group in ICU. We observed that in high flow oxygen therapy failure group, the patients were older. They had lesser SpO2. They had lesser PF ratio, which was significant. The patient in high flow oxygen therapy failure group, they had lesser ROX index and they had higher heart rate, which was also significant. We found that the patient in failure group, they had higher Apache 2 score, they had higher SOFA 2 score with high D dimer and interleukin 6, which were all of them were found to be significant. In primary outcome, we observed that in success group, there was improvement in oxygenation at 1 hour, 6 hours, 7 hours, and 14 days. 7 days and 14 days. And that was consistent. But in failure group, we saw that we observed that there was improvement in oxygenation, but that was not consistent. Patient reported immediately that they had improvement in dyspnea and they had improvement in comfort level, and that was measured by dyspnea box CR10 scale and comfort visual analog 10 scale, and that was Fidelman test were used in this. We compared our study with some of the studies of similar nature. Despite having a ROX index and lower PF ratio at baseline, our patient had successful outcome on high flow therapy compared to that observed in other studies. Large prospective cohort study was our main strength, and another discrete observation which was not reported before, but we found it in our study, that there was improvement in dyspnea and comfort score. To conclude, High flow oxygen therapy significantly improved oxygenation level in COVID-19 patients developing acute hypoxemic respiratory failure. However, the determination of risk factor for high flow oxygen therapy failure needs further trials. Thank you.
Yeah, thank you, Dr. Raman Kumar. We will have next talk by Dr. Kiran S. We will have the presentation slide. So Dr. Kiran S will present the comparison in lactate levels with respect to veno-arterial levels and carbon dioxide gap during the initial resuscitation of patients in SOC. So I will invite Dr. Kiran, who is a part of Armed Forces Medical College, Pune. Dr. Kiran.
I am Major Kapil, final year resident anesthesia from Armed Forces Medical College, Pune. My guide is Colonel Kiran S. My topic was to compare the change in lactate levels with respect to the veno-arterial carbon dioxide gap during initial resuscitation of patients presenting with shock. Present guidelines for hemodynamic management of patients coming in with shock recommend the use of markers of tissue hypoxia as resuscitation endpoints. In the initial part of resuscitation period, either targeting the central venous oxygen saturation or the lactate clearance or combination of both is generally accepted. However, as we all know, lactate levels are affected by factors other than global hypoperfusion in critically ill patients, as in type B lactic acidosis. The PVA-CO2 gap, that is the difference in the partial pressure of carbon dioxide between the central venous blood and the arterial blood, is also a downstream metabolic parameter which has been explored in resuscitation of patients presenting with shock. And PVA-CO2 gap of more than 6 millimeters of mercury indicates a low output state with tissue hypoperfusion. And such patients can continue to receive resuscitation in spite of normalization of other markers like the SCVO2 or the lactates. Hence, we hypothesize that the CO2 gap has a correlation with lactate clearance and the mean lactate levels in shock patients being resuscitated. That both are covariant and are downstream indicators of improving tissue oxygenation. The aim of my study was as indicated in the title, and my objectives were to compare the mean lactate levels and the lactate clearance with respect to the PVA-CO2 gap after 6 hours of initial resuscitation of patients presenting with shock. And my secondary objective was to study the correlation of the CO2 gap with mortality during early resuscitation period in patients with shock. It was a prospective observational study over an 18-month period conducted in 67 adult patients who were admitted with diagnosis of shock from all causes to a multidisciplinary ICU in a tertiary care center. And the serum lactate levels, the VaCO2 gap, and the hemodynamic variables like NIBP, heart rate were obtained at ICU admission and 6 hours after admission and resuscitation. These tests were done using point of care equipment, and all patients received standard of care as required for shock. And variables like the ICU length of stay, need and duration for mechanical ventilation and renal replacement therapy, days of vasopressor need, and mortality within 28 days were also recorded. Statistical analysis, data on categorical variables are presented as N, that is percentage of cases, and data on continuous variables were presented as mean and standard deviation. And the intergroup comparison of means of the continuous variables was done using the independent sample t-test. And the correlation analysis, which was our main objective, was done using the Pearson's method. Coming on to the results, you can see two scatter graphs. The image on the left shows the correlation between the serum lactates and the PVCO2 gap, which shows a positive R value, that is the Pearson's coefficient of 0.320, which is statistically significant. This shows that both these markers are have a decreasing trend. That is, if one decreases, the other also goes down with it. Hence, it indicates they both are covariant. That is, they are linearly correlated. And the second image on the right shows the correlation analysis of the PVA-CO2 gap with the lactate clearance. And this gives a negative R value of minus 0.380, which is also statistically significant, which clearly shows that with evolving period of resuscitation, as there is increase in the lactate clearance, the CO2 gap goes down, and hence both are linearly correlated. Coming to the distribution of the outcome measures in the study group, as you can see, more number of patients required mechanical ventilation, about 70.6%, and most of the patients required vasopressor support, although 57 cases out of the total sample required less than 7 days of vasopressor support, and the length of ICU stay was less than a week in about 63% of our cases, and more than a week in 36.8% cases. In the mortality group, around 50% of our patients survived, and around 48 to 49% of our patients expired. This table shows the distribution of the CO2 gap and the serum lactate levels according to the significant outcome measures. So this has been measured both at the time of admission and 6 hours after resuscitation. So if you look at the renal replacement therapy requirement, patients who had higher CO2 gap at T0 as well as at T6, higher number of patients, those patients required renal replacement therapy, and the same applied to the serum lactate level groups as well. In the group of mechanical ventilation, if you look at the serum lactate group, both at T0 and T6, the patients who had higher mean lactates required mechanical ventilation as required to patients who had lower lactates. And looking at the mortality, as you can see, at the end of 6 hours of resuscitation, in both the groups of CO2 gap and serum lactate, more number of patients survived who had lesser CO2 gap and lesser lactate as compared at the time of admission, which indicates that they are good indicators of mortality, although they were not statistically significant at the start of the study. Hence, we recommend that while using metabolic parameters to assess resuscitation of patients in shock, a combination of these values recorded at regular intervals or serially, along with dynamic parameters such as lactate clearance, will help in good clinical decision making and deciding further treatment course, and prevent overzealous administration of crystalloids and avoid complications like fluid overload. So to conclude, lactate values have good correlation with the veno-arterial carbon dioxide gap and can be used effectively to assess the quality of initial part of our resuscitation for patients presenting to the ICU with circulatory shock. And the CO2 gap is a good predictor of poor outcomes in circulatory shock. And these dynamic lab variables, when used along with clinical parameters, definitely have a role to play in improving outcomes in shock patients being resuscitated. With this, I end my talk. Thank you.
Thank you, Dr. Kiran. Now we will go to the next presentation by Jivokov Joshi. Dr. Joshi, over to you. Can I have the Dr. Joshi slide?
I am Dr. Jivokov Joshi. I am going to present alcohol septal abjection for hypertrophic cardiomyopathy. This is by Dr. Jivokov Joshi and cardiologist and other teams member of Tagore Heart Care. I am MD Anesthesia, FCCS, CCP, Head of Department and Director Critical Care, Tagore Hospital, Jalandhar, Punjab. A 56-year female presented to us with dyspnea of exertion and chest pain. On examination, her heart rate was 80 per minute. Non-invasive blood pressure is 170 by 80 millimeter of mercury, and respiratory rate was 24 minutes. On investigation, our hemoglobin is 12, TLC is 11,200, and other tests are within normal again. On X-ray, there is a sign of pulmonary hypertension. And on echocardiography, there is a finding which show hypertrophic cardiomyopathy and our LVO2 gradient is 90 millimeter of mercury. After thorough investigation, clinical examinations, and echography and X-ray ECG, we decided to rule out coronary artery, and for this we have done angiography. And her angiography is normal, and from left anterior descending, there is a one septal branch is coming, large septal branch is coming, and this is the culprit vessel which is producing this hypertrophic cardiomyopathy. In cath lab, we have decided to block this artery, and after thorough preparation and informed consent by the relatives, next day we have taken this case in cath lab, and in cath lab we have injected 2% alcohol and septal branch of left anterior descending. And before injecting, once more we have measured her LVO2 gradient, that was 90 millimeter of mercury, and after injection of 2% alcohol and septal branch of LAD, our LVO2 gradient reduced to 30 millimeter of mercury. And with this injection, our gradient reduced to almost normal. ASA is a well defined and very minimum invasive technique, but this is associated with lot of complications like complete heart block, myocardial infarction, cardiac tamponade, coronary artery spasm, coronary artery rupture, and with this all the events, patient may have myocardial infarction, shock, and some patient may require PPI and some may require angioplasty or bypass surgery. So with this alcohol septal ablations, we have to be very careful. Our team should be very expert to do this in a very precise and safe manner. ASA is a very good minimum invasive technique, especially those cases in which lot of comorbidities are there, like COPD patients, patient is having a stroke, patient is having renal failure, or other systemic illness in which patient surgically is not fit for a gold standard surgery for hypertrophic cardiomyopathy. So in our case, we have selected this guy, this lady, evaluated it completely, and after informed consent, we have done septal branch of LAD, 2% alcohol injection, and with that, our LVO2 gradient reduced from 90 to 30 millimeter HC, and very good results. And she is in our follow-up for last 6 months, still her gradient are 35 millimeter of HT and totally asymptomatic. So this is the slide which show our gradients post procedure. This is the gradients. This is our cath lab slides which show all the pressures. With this is Dr. Joshi, Head of Department and Director Critical Care, Tagore Heart Care, thanking you for giving me this opportunity to share. This is the one of the minimum invasive technique for hypertrophic cardiomyopathy. Thank you very much.
Thank you, Dr. Joshi. I think we will come to the last presentation of this session by Dr. Renu Sutar. I will invite Dr. Renu Sutar's presentation. Dr. Renu Sutar is a part of a pediatric neurology unit in PGI JIPMA. I request Dr. Renu Sutar to present her presentation. Dr. Renu Sutar.
Good morning all. My name is Dr. Renu Sutar. I am Associate Professor Pediatric Neurology Unit at PGIMER, Chandigarh. The title of this study is Efficacy and Safety of Levetiracetam versus Phenytoin as Second-Line Anti-Epileptic Agent in Pediatric Convulsive Status Epilepticus a systematic review and meta-analysis of randomized controlled trials. So pediatric status epilepticus is the most common neurological emergency and associated with mortality in approximately 10% children. Benzodiazepines are the first-line seizure medication for pediatric convulsive status epilepticus, and a second-line anti-epileptic agent, phenytoin, fosphenytoin, levetiracetam, and valproate are used. Though phenytoin remains a preferred second-line anti-seizure medication, however, it is associated with significant adverse events. Recently, levetiracetam is emerging as a second-line anti-seizure medication. It has similar efficacy to phenytoin, but reported to have a better safety profile, can be easily administered, and require less intensive monitoring, has a better drug interaction and pharmacokinetic profile. So in this meta-analysis, we plan to study the efficacy and safety of levetiracetam in comparison to phenytoin for pediatric convulsive status epilepticus. So the articles were searched from the PubMed, Embase, Google Scholars, Scopus, Sinhal, and Cochrane systematic reviews and database. Inclusion criteria were all the randomized controlled trial published between January 2000 to November 2020, assessing efficacy and safety of levetiracetam and phenytoin as second-line seizure medication for pediatric convulsive status epilepticus. So among the selected studies, data was extracted for the primary and secondary analysis. Primary outcome was considered as achievement of seizure cessation within 5 to 60 minutes of completion of study drug infusion. And the secondary outcome studied was seizure cessation within 5 minutes, time to achieve seizure cessation, seizure recurrence, and requirement of intubation and mechanical ventilation. The data was analyzed with Revman software, and quality of the randomized control trial was assessed with Cochrane risk of bias tool. So a total 6,431 articles were screened, and among these 12 randomized control trial who fulfill the eligibility criteria were selected, and these 12 randomized control trials involved 2,293 pediatric cases of convulsive status epilepticus. So the primary outcome for this meta-analysis was achievement of seizure cessation within 5 to 60 minutes of completion of study drug, and we can see 82% children in the levetiracetam arm and 77% children in the phenytoin arm could achieve seizure cessation. Both the groups have similar efficacy for this primary outcome analysis. Among the secondary outcome analysis, seizure cessation within 5 minutes of study drug infusion was studied, and we can see 60% children in the levetiracetam arm and 65% children in the phenytoin arm achieve seizure cessation within 5 minutes. So both the groups have similar efficacy for achievement of seizure cessation within 5 minutes. Another secondary outcome analysis was seizure recurrence within 1 to 24 hours of study drug infusion, and we can see 17% children in the phenytoin arm has seizure recurrence. In comparison, only 10% children in the levetiracetam arm has seizure recurrence. This difference was statistically significant and in favor of levetiracetam. Another secondary outcome studies were time to achieve seizure cessation following completion of study drug infusion. The time varies from 3 minutes to 30 minutes in both the group, and both the groups has required similar time to achieve seizure cessation. Among the safety outcome analysis, requirement of intubation, mechanical ventilation, and cardiovascular instability was studied. We can see 21% children in the phenytoin arm required intubation, while only 14% children in the levetiracetam arm required intubation and mechanical ventilation, and this difference was statistically significant and in favor of levetiracetam. In both the group, 10% patients had cardiovascular instability measured with episodes of hypotension and cardiac arrhythmia. The quality of the study was assessed with risk of bias, Cochrane risk of bias tool, and we can see the studies were at high risk of bias, and the Fanel plot also showed there was a publication bias in these randomized control trials. So to conclude, in this meta-analysis, the result shows levetiracetam and phenytoin have equal efficacy as second-line anti-epileptic agent for pediatric status epilepticus. Though efficacy is similar, phenytoin group has higher number of seizure recurrences within 24 hours and higher number of patients required intubation and mechanical ventilation. The strength of this meta-analysis was rigorous search strategies, and both safety and efficacy outcomes were evaluated. And among the limitations, the 12 randomized control trial used variable primary and secondary outcome. Variable doses of levetiracetam and phenytoin was used, and variable duration of infusion were used. 9 among these 12 randomized controlled trial are at high risk of bias because of lack of allocation concealment and blinding. And some of these studies had very small sample size. And there is marked heterogeneity in the among these 12 randomized controlled trial. So the conclusion is that both the drugs has got similar efficacy for achievement of seizure cessation, but the safety profile of levetiracetam is better than phenytoin. Thank you.
Yeah. Thank you. Can somebody on the video, please? So this ends the session of the paper presentation. Dr. Gansam, can you come back? Are you around?
Yeah, Venkat.
Yeah. Any concluding remarks?
No, I thank all the speakers for their presentation in the Cricket 2021. I wish them all the best of luck. We will disclose the results soon. We'll discuss with the organizing team and display the results after giving the results.
Thank you.
Okay.
Thank you, Dr. Gansam, for your evaluation. We will move on to the next session because of lack of time. We will move on. So we have some. Can I go to the next session with pro and con? Yeah. So we have some vibrating next sessions of pro and con debates coming up with two seasoned dynamic speakers on board for that. Trust my experience more than an RCT in decision making. We have Dr. Ramraj Gopalan. We all known and learned from him for the last 27 years of critical care medicine of ISCCM. So he will be speaking on pro to that. So we will listen to him first, and then probably by a con debate by another seasoned speaker of the time, Dr. Praveen Amin. So I now invite Dr. Ramraj Gopalan sir for his first pro debate on this.
Sir, it's the same.
Okay. Today's debate has been centered on whether I believe experience or randomized controlled trials to guide my management of my patients. And I'm going to defend the position that it is my experience that probably is far more important than just looking at randomized controlled trials. I think this is a pretty unusual position for me to take, primarily because I too, over the last several years, have been somebody who's worshipped at the temple of evidence-based medicine with the chief deity, that is the randomized controlled trial, being right at the peak. But over a period of time, I have become skeptical about this position. And this is not a skepticism that has come out of a growing senility, growing older, and having a feeble mind or fickle thinking, but it is clearly something that I have probably come to understand over a period of time where I've seen that randomized controlled trials don't allow me to answer what is most essential as a question that I would ask if I as a clinician. Number one, is this a treatment that is proven in this so-called randomized controlled trial that is going to help my patient, this specific patient of mine? And that is basically the question that I want to answer from these randomized controlled trials. And when I really look at it over a period of time, it has been quite disappointing. And this is just a spectrum of studies in intensive care medicine where randomized controlled trials, well, for the last couple of decades, have not been answering this kind of a question. On a consistent basis, they seem to demonstrate absolutely no difference between what we would consider as very important therapies. It is not just in one area. It is from areas starting from ventilation, going on to renal failure, to nutrition, which happens to be Praveen's favorite end of the spectrum. And there is also issues related to hemodynamic management and to fluid therapy, which really have not demonstrated any kind of benefits in these randomized controlled trials. So the question that we always need to ask is, why has this happened? And I think it's very easy to understand if you understand the fact that all randomized controlled trials are not the same. There are clearly two specific classes of randomized controlled trials that we see.
And these randomized controlled trials can be either divided into what we call efficacy trials, which are basically attempting to demonstrate the efficacy of a specific treatment, which unfortunately are not easily extrapolatable. And the other side are trials which are called pragmatic trials, which are generally very universally applicable because they are applied in a large number of patients, but do not ever demonstrate a valid efficacy of a specific treatment. I think I need to probably spend a little bit of time trying to explain what I mean by these two kind of trials. And I think that will form the basis of my argument of rejecting randomized controlled trials as valid information for the management of our patients. So let me start with the efficacy trials. These are classically the situations where you want to try a specific treatment to see if it translates into an improved outcome, very specifically in terms of, say, survival or weaning from a ventilator is typically what we in the intensive care unit will worry about. These efficacy studies are clearly best demonstrated if you have a very homogeneous group of patients. These patients, if they are very identical to each other, they will have very few confounders within the group. And when you apply such a treatment and compare it with a non-treatment or with a placebo, you will be able to demonstrate a significant difference between the two. And this very, very clearly requires a very narrow selection and a very narrow case mix. So it's not very atypical for you to see that in a randomized controlled trial, which is aiming to demonstrate efficacy, you will start recruiting a very large number of patients. Maybe in this particular example, about 40,000 patients are being recruited, but ultimately only 10 to 15% of them will be included in the randomized controlled trial. You might want to say, okay, so what? It's very likely that these randomized patients are representing the larger population of about from which they are selected. But that is not absolutely true, because there is data, for instance, from registry data, where patients who are not included in randomized controlled trials have been compared to the patients who are in randomized controlled trials. If they were just eliminated despite their eligibility, just because they didn't, I mean, it was too large to be, the study was too large to recruit everybody, or rather too small to recruit everybody. Under those circumstances, these should be comparable patients to the patients who were in the randomized controlled trial. But as you notice from this graph, there is a significant difference in short-term and longer-term mortality between these patients, suggesting that inclusion in a randomized controlled trial alters outcome by itself. The so-called Hawthorne effect is pretty well known. So this raises a very strong concern that when you are included in a randomized controlled trial, you are not representative of the overall population, and therefore to extrapolate from the results of the randomized controlled trial to general practice is probably quite difficult. This is nicely demonstrated in this particular study. This is all of us are very familiar with the so-called HARAKA trial, which looked at hypothermia after cardiac arrest. When you look at it broadly, it seems to imply that this was application of hypothermia in all patients with cardiac arrest. But if you look at the trial, it was a very specific, narrow subgroup of patients that they selected. Patients who had a witnessed out-of-hospital ventricular fibrillation or ventricular tachycardia effect. Okay, it was not in all patients with, say, even PEA or asystole. They were classically in an out-of-hospital situation where they got early access to emergency medical support, and they were initiated on CPR as rapidly as is possible, and then ultimately achieved return of circulation within 60 minutes. And this is not the kind of population that I see in the vast majority of my patients. So for me to extrapolate the idea from this HARAKA trial to all the patients that I have with a cardiac arrest is absolutely untenable. And this is what we need to recognize of most efficacy trials. They're too narrow that even when they demonstrate a benefit, that we cannot extrapolate them to routine clinical practice. On the other side of the spectrum are the so-called pragmatic trials. These are studies that look at the effectiveness of a therapy in a broader population in the ICU. And as a consequence of this broader inclusion criteria, you're going to get a very heterogeneous group of patients in these groups. And as a consequence of this, these groups are usually selected by very loose criteria. And if the focus in most of these studies is to acquire very large numbers so that you can have statistical precision, you end up with studies that are heterogeneous in terms of the patient population and probably have selection criteria and experimental design that can be, very questionable. And my favorite example of this is this famous SAFE trial, which claimed that there was absolutely no difference in terms of safety between albumin and saline. They achieved a randomization of roughly about 7,000 number. But how did they achieve it? They achieved it by using extremely low the selection of these patients, a heart rate greater than 90, a blood pressure of less than 100, CVP, which we know is not necessarily very good, capillary refill of greater than 1 second, and a urine output of less than half ml for 1 hour. These are extremely sensitive criteria that I almost always joke that if you had been walking through an Australian or a New Zealand ICU at the time of the study, you too would have been randomized. Just imagine what these studies will demonstrate. Very clearly, that's what we saw in the SAFE. It was ultimately demonstrating that there was no difference between albumin and saline in a group of patients who were very heterogeneous, who were generally not very sick, and who didn't get very large volumes of albumin. And as a consequence, this study was doomed to show no benefit. It is very extrapolatable because it represents the general population, but it cannot show efficacy. And that is basically the entire problem with randomized controlled trials. The studies which have to demonstrate a scientific accuracy are extremely narrow in their selection of patients and cannot be generalized. And studies which can be generalized and are usually very large and demonstrate huge statistical precision usually never confirm the efficacy of a specific treatment. So either you have efficacy or you have generalizability. And that unfortunately is a very bad compromise when we are trying to look at all these studies. So if I was to look at all the studies that I initially showed you, it ultimately has been virtually useless in terms of changing our practice patterns over a period of time. Additionally, in the rare circumstance that a randomized controlled trial demonstrates a difference, it does not answer the question that I am most interested in. My interest is in knowing whether my treatment will work on my patient. And what these studies will show you is that it works on average in a large population. That is not what I'm interested in. I want to know what is happening to my patient. And this tendency to look at averages is what I would call the flaw of averages. You can always say that the average depth of this lake is only 3 feet and you will not drown, but the average depth doesn't represent the entire spectrum of the depth of the lake. And it is distinctly possible that you can drown as a consequence. Then this I would like to extrapolate with this classic example of the ARDS net high PEEP and low PEEP study. Very clearly, when we used a very high PEEP under these circumstances, we were demonstrating significant improvement in oxygenation, but it didn't translate into any differences in terms of outcome. And that is because patients were randomized very broadly without looking at the characteristics of the lung that was subjected to this higher low PEEP. So in each group of these patients, you would have a significant proportion of patients with recruitable lungs and a significant without recruitable lungs. And as a consequence, the application of PEEP at various levels are probably going to be benefiting each one of these subsets in a very different way. And ultimately, there is going to be no difference because the average effect is going to be the same in either group. And this is the sad problem with most randomized controlled trials. They look at average outcomes and they look at situations that are either not easily verifiable or extrapolatable. And as a consequence, I think we need to look at them completely all over again. The classic randomized controlled trial is built on what we call the OXO or the OXO paradigm, where basically it's an issue of taking a study where you observe a specific parameter, you give a specific treatment, but you perturb it, and then ultimately observe what the outcomes are. And what you can do with such a design is only test whether a specific treatment works. It doesn't tell you, and particularly it's also whether it works on average. Okay. In contrast, it doesn't tell you what I am concerned about, not on whether it works, but I am concerned about how does it work and what are the circumstances that make it work. And this we can easily derive into what we call the CMO kind of a paradigm, where we look at the mechanism that it works under, the context it works under, to make a prediction of what the outcomes are likely to be. Just to take it in a very farcical kind of a manner, I would say that I don't need a randomized control trial, for instance, to prove that parachutes are effective when I jump out of a plane. Very clearly, I know the context. The context is that the fact that I will develop a lethal injury when I jump out of such a plane. But also I know the mechanism that the parachute will retard the velocity of fall quite significantly. I don't need to throw a bunch of people out of a plane with or without a parachute to be able to demonstrate the efficacy. The mechanism is understood and the context is relevant, and as a consequence, I can make a prediction of the outcome. So if I was to be less facetious and look at it from most of our clinical studies, I would clearly say that we can understand the mechanism in several ways. We don't always need an efficacy randomized control trial to say that the mechanism is this and this is how it works. On the other hand, there are several ways in which we can acquire this information. What is very relevant for us is, once we know the mechanism, it is the knowledge of the context of the situation that really makes a big difference in terms of outcome. And I can give you an example again, as we were talking about the high PEEP strategy. If I knew that my lung was recruitable, my tendency to use a high PEEP despite that negative trial would be something that is logical. I would go ahead and apply high PEEP if I know my lung will recruit. And this requires a set of information that we can easily call as your clinical judgment. It is something that does not come in randomized controlled trials. Right, so with this as the background, I'd ask Praveen, simple question. Praveen, you're both interested in nutrition, and now you are the strong supporter of the randomized control trial. And way back in 2014, the calories RCT very specifically said that TPN is not superior to enteral nutrition. Have you been very faithful to this so-called divine call? I can almost promise you that despite your knowledge of this trial, there have been several times that you have gone ahead and said, I think I will have to put it in the right context. And that is exactly what I'm trying to emphasize. Randomized control trials do provide us with some kind of mechanism, but it has to be contextualized. It has to be interpreted in the right context. And that is what we would call as experience. I believe that that experience is absolutely necessary for us to make any kind of a genuine call in terms of managing our patients. As our understanding of scientific methods has been evolving over a period of time, we clearly recognize that there are limits to the randomized control trial. Randomized control trials are clearly informative. There is no question about that, but that information needs to be contextualized. And the only way in which you can achieve this is by using what we call as experience is far more important than a randomized control trial in making clinical judgments. Thank you very much.
Thank you, sir. Thank you for that wonderful.
Thank you. I noticed that there was some lag in between, and there was a dropping of the sound, and some of your words didn't come. Please let me know when I can start. And we've had my good friend Ram give you a perspective about how good he is with his experience, which I'm certain he is, no question about it. I'm kind of pretty pleased with the way I have to start this presentation by actually showing my good friend Ram, who tends to conduct all these yearly reviews across, which is purely evidence-based. So I guess he believes in what I'm going to be saying, and he probably endorses it, which I'm certain he will in the end. But like I said, if you look at all his presentations, there is always evidence backed in his presentation, and he will quote papers after paper. So, before we start this pro-con debate, I know that Ram agrees with exactly with what I'm going to say. So when Ram says that experience is important, but if you look at the real definition of evidence-based medicine, it will tell you that it is the integration of best research evidence with clinical experience. That component is clearly there. I mean, you got to be a competent, experienced physician to implement all the research that you have looked into and read into these literature and understood the literature, and of course implement with all the experience that you have and look at patient values. So it is integration of all these three parameters, that is integration of the best research, clinical experience, and patient values. So I'm going to stick to the pandemic because that's what we are going through, and I'm not going to go through all the past literature. How in this pandemic did we actually go about implementing evidence-based medicine, and what did we do different? And since the pandemic started, how did we go about treating patients in the pandemic based on evidence-based medicine? We know that all of us, Ram showed this slide too, in terms of what is EBM mantra and what are the levels of evidence that we all look at. And conventionally, when we looked into the pandemic, we were looking for what is the best form of therapy for our patients when we treated them in the pandemic, because there was ongoing research, there was new evidence unfolding ever so frequently, and we needed to analyze this data and try to implement it during the pandemic. So we know that evidence is constantly and continuously changing. We need to make decisions on either indirect evidence, realizing that some of these decisions may be wrong. And I'll show you evidence to show you that what we did in the initial part of the pandemic was something may have been wrong during that point of time. And then we changed our practice because there were more and more evidence telling us that what we did was probably wrong, and what we need to do is something completely diagrammatically opposite of what we were doing. Realize that there may be better decisions than the ones that we made now. So probably 3 to 4 months from now, we may change what we are doing now. We won't know till all this is over. So till the pandemic is over, we won't know what is the best form of therapy that we should be using in our patients. So there is a host of information that is coming out, and with the social media being so prominent, there is so much of information and misinformation floating around. So we need to integrate all this information, and we need to understand what is the right information and what is the most appropriate information. If you look at this glass, some may say it is half full and some may say it's half empty. So we need to understand what is the right form of information that we need to implement in the therapy of our patients. So that's very, very important. Integrating these information, analyzing this information, and then implementing it in our patient care. Our patient, what we need to do is to make certain that our patient gets the right form of treatment, and not only in the treatment, the right form of diagnosis. All this comes into play, and this is where evidence-based medicine plays a major role in how we practice medicine. Every intervention that we do has a potential for harm. There are, everybody talks about face masks, about social distancing, about hand washing. Now, everybody talks we need to wash our hands frequently with alcohol. Now, have you looked during the epidemic, during the pandemic, how many people have got eczema because of the hand washing with the alcohol? So there are potential harms and potential benefit, and we need to identify this and make certain that we are able to implement the beneficial effect of the evidence that comes in light of the research that is continuously ongoing in the treatment of this pandemic. What about tests? We had a lot of different types of tests which were available to prove the diagnosis. So let's not confuse test results with the absence or presence of the disease. Positive tests can be falsely positive. Negative tests can be falsely negative. This is what evidence-based medicine has shown us. Learn about the characteristics of some of these common tests that we perform, and also we need to perform, when we perform on rarer tests, and especially when they have a high impact on our management, we need to understand when we perform these rarer forms of tests which have a high impact in the diagnosis of our patient. Tests that have a high specificity are pretty good at ruling in the diagnosis if they are positive. Tests with high sensitivity are usually good at ruling out the diagnosis if they are negative. Most importantly, if we run tests on someone who is unlikely to have a disease and the results comes back positive, there is usually a good chance that this may be a false positive. So one needs to, when we look at all the evidence, we need to sometimes use our experience too, which I agree with Ram that we need to use common sense in certain situations, and that's very important when we run our tests in our patients. What about clinical disease in this pandemic? We know that there is a wide range of diseases. You have mild and moderate disease, you have severe disease, and some of them critical. Now, patients who fall in this category cannot be compared with patients who fall into this category. So we are going to be looking, especially in the ICU population, at patients who are with severe disease and critical disease. So when you look at the whole population of the COVID-19, it may not be the same, and the management of each of this will be different. So one needs to look at what are the evidence which says you need to do a particular form of intervention in the more critically ill one as compared to the ones with the moderate disease. So we need to understand, looking at the data, how to approach each of these subset of patients who have the same disease. So we need to understand some of them may have more multiple organ dysfunction, some of them are confined to one organ dysfunction. How do we approach these patients? So it's very important at looking at evidence in these group of patients. Now look at all the therapy that has come and gone. Now here we have seen steroids which have really marked in green. Then there are some which may be beneficial, and some of them which have been, used in the initial part of the pandemic and then subsequently shown that it may not be beneficial. And some of them has come back. What was shown not to be beneficial has probably come back. So this is how we evolve when we look after patients. We keep looking at new evidence and we then try and implement these new modalities of therapy into our patient care. And that's what we really out to look at to improve patient outcomes. And that's what evidence-based medicine helps us in improving outcomes in our patients. Just to give you some example, when initial part of the pandemic, this particular molecule was in big vogue, hydroxychloroquine. There was certain research coming out from Chinese researchers who said that patients who were on hydroxychloroquine when they had SLE didn't become infected with SARS-CoV. And of course, this very brave French maverick called Didier Raoult went about promoting it in a very big way, saying that this was a wonder drug, and based on some very skewed data that he published. Didn't really publish in the peer-reviewed journal, but he went and put it out in the social media saying that this was a very good form of therapy to treat patients with COVID-19. When the evidence came out, when we looked at the recovery trial, a large group of patients, and again, when we looked at the Brazilian study where they looked at azithromycin and COVID-19 in COVID-19 patients, a combination, and this coalition study, which is a recap study where they actually showed that this was really not beneficial. So clearly strong evidence to say that this modality of therapy was really not working in patients with COVID-19. So there, in the initial part, it was being used predominantly, and subsequently, now I don't see any physicians actually using this molecule anymore. Then came the steroid, and the recovery steroid trial had a big impact in the outcome. And, most of these trials were rapidly published because of the onset of pandemic. And clearly, here was a pretty good trial which looked at steroid in group of patients, especially dexamethasone, clearly showing great benefit in terms of reduction in mortality, in time spent on ventilator, and patients on non-invasive oxygen. So clearly benefit. There is a absolute mortality reduction, in these group of patients. Clearly quite significant, 17% overall reduction, relative reduction in mortality. So steroid therapy, when we began to understand steroid therapy in the pandemic, you realize that early administration during viral shedding may be harmful, may be used later, as shown in the trials, that they may be more beneficial, as shown in the recovery trial. 6 milligrams used for up to 10 days. And you could use an equivalent dose of steroids like oral betamethasone, IV methylprednisolone, oral prednisolone in equal doses. Of course, the REMAP CAP study, which actually they cut short, which was recently published in the JAMA, where they used hydrocortisone in 2 different setup of patients, those with shock or a fixed dose schedule, showing superiority and improvement in organ support-free days within 21 days. When we look at all the meta-analysis put together in all the studies, which is the DEXA study, the CODEX study, the recovery trial, the Cape COVID, the COVID steroid trial, the REMAP CAP study, and of course the steroid SARI study, all of which when clubbed together showing a clear mortality benefit. So one intervention which has clearly shown benefit in patients with COVID-19. So these are, what about remdesivir, antiviral therapy? There are these 2 trials which have actually showed that they accelerate recovery by 1 to 4 doses. No real great benefit in mortality. The initial part, they showed the possible reduction in mortality, but subsequently, when they followed up this patient, there was no increased mortality. So this comes in an area where it might be beneficial if used early. So that's very important to understand. Probably we need more information of this. And here's a modality which really has been in, out, and may come back in again. And this is the interleukin-6 pathway inhibitors. As you can see, 2 studies showing benefit and 2 studies showing no benefit and increased risk of secondary infection, because this is an immunosuppressive molecule, as can be seen. Some studies showing it's beneficial. And of course, the company went ahead and did a large randomized control trial, and they didn't find any benefit. In fact, they found higher incidence of infection. This was never published yet, but this was conducted by the company, pretty large double-blind randomized global study, which didn't show any benefit. Now we've got 2 studies which have looked at this, and this is it is probably being peer-reviewed. So we've got a fast preprint version of it, which can be seen in the recovery trial, clearly showing benefit in patients when they use this molecule early, and likewise when they used it in the REMAP CAP study, again a study which shows that this is beneficial. So once we wait for the real published version after it gets peer reviewed, we might have to re-implement using this molecule in our patients with COVID-19. What about convalescent plasma? Here's an Argentinian study which showed when they used this molecule, there was no benefit. And again, another group in Argentina showed that in the elderly population, more than 65 years of age, if you use convalescent plasma with a high titer early, there was possible benefit in these group of patients, especially in those patients who have high titer plasma values of IgG in the convalescent plasma. So what do we learn from evidence? That when the evidence comes in, we need to understand it. We need to see how we can implement these modalities which have been tested across various centers and in good centers, and gets published in peer-reviewed journal telling you that these modalities of treatment leads to highest quality care and patient outcomes. It reduces healthcare costs, it increases reimbursements and reduces denials, especially when it comes into the Western world. It reduces geographical variations in delivery of care, which is very important across all boards and patients, especially in the most critically ill patients. It increases clinical empowerment and the role of satisfaction. It reduces healthcare provider turnover rate, and it meets the expectations of an informed public. And of course, we should realize that, there are limitations in medicines, and sometimes we should be bold enough to say that we still do not know what to do. We try to do what is best for the patient with available evidence to it, and do not hesitate in saying we do not know. Like most people, the politicians and people in the medical community also would want to deny this fact that we don't know everything in medicine. And it is a fact that there are sometimes it is wise to say that we do not know when we really do not know what is the form of therapy that we may need to implement in a certain group of patients. And that was learned by people who went on promoting this particular French maverick person has got legal thing facing against him. And we also know what this particular this gentleman did when he went said, I'm taking hydroxychloroquine, and he spoke about bleach and things like that. He was voted out. So I'd like to complete by saying, I quote my dear friend, Professor Ramu, when he quoted that expert is a man who makes three correct guesses consecutively. So thank you very much, Professor.
Thank you, Praveen. I'm very impressed by your knowledge of COVID, but I don't think you are very relevant to the specific topic of the debate. If there is anything that I would just like to pick with your long presentation, is the fact that when you talked about randomized controlled trials related to tocilizumab, very specifically with the interleukin inhibition, this is a proof that randomized controlled trials don't mean anything. The whole range of randomized controlled trials demonstrated no benefit, and then there are other trials that are demonstrating a benefit. Now, you're going to be very selective about how you pick which is what you're going to choose. I think we need to be very, very careful that interpretation of randomized controlled trials has to be very carefully done. I feel, for instance, the data from the manufacturer, which basically said that there is an excess of mortality because of infection, is something that we need to be very clear. That may be the context. The context would be, if I use tocilizumab in India, I'm more likely to kill patients despite the fact that I may be allowing them to recover from their COVID. I will hurt them from a nosocomial infection. It may not be so bad in a Western situation where it turns out to be beneficial. So very clearly, when I'm interpreting this data, I can't just look at the randomized control trial.
Yeah, thank you. Just can you on my video? Yeah, thank you for that wonderful debate from both seasoned speakers. Now we will roll on to the next topic. We have an interesting panel discussion. This is from the industry session of Alchem, and this panel discussion will be moderated by none other than Dr. Subal Dixit, our past president and a seasoned campaigner in the ISCCM areas. And now I'll request Dr. Subal Dixit sir to introduce the panelists and carry on the panel discussion. Over to you, Dr. Subal Dixit.
Yeah, thank you, Venkat, and we will start with the presentation. I request the team to please start the presentation. Welcome, Dr. Mehta. Hello, everybody, and welcome you all to this panel discussion at the virtual Criticare 2021. On behalf of the Indian Society of Critical Care Medicine, I thank Alkem Pharmaceuticals for their generous support for this session. I would also like to welcome the eminent panelists for today's session, Dr. Yatin Mehta, who needs no introduction, and he is the past president of the Indian Society of Critical Care Medicine, and he is the president of the Sepsis Forum of India. We have got Dr. Kapil Jirpe along with him, who is also the past president of the Indian Society of Critical Care Medicine and the current president of the Society of Neurocritical Care in India. We have got Dr. Shushruta Bandopadhyay, who is the director of critical care at the Amri Hospital in Calcutta, and Dr. Kushrao Bhajan, who is the young dynamic intensivist from Hinduja Hospital. He is the director of critical care at the Hinduja Hospital in Mumbai. So these are the four eminent panelists who have got vast experience in critical care and also on today's subject on the use of this novel aminoglycoside, which is arbicacin, into the Indian scenario. So welcome all. Again, thank Alkem for inviting all of us, and again thank Alkem for their generous support for today's session. So without wasting much time, I would like to set the ball rolling here by asking the first question to Dr. Yatin Mehta, that what is the current scenario of antibiotic resistance in Indian ICU settings, the prevalence of MRSA in the critically ill patients?
See, the MDR organisms or NPI infections are increasing exponentially in the Indian subcontinent and more so in India, which we have seen in the INDICAP study also. The second paper is now coming out on INDICAPs. Also, if you look at the EPIC-2 study, the hospital-acquired infection was quite high, and MDR also had increased. EPIC-3 has also been published, which has also shown further increase in MDR. In the EPIC-2, MRSA was the major problem in the Western ICUs, but in the EPIC-3 study, the gram-negative sepsis is also increasing. But MRSA has been increasing in India, and Dr. Bhajan is from Hinduja. I think one of the first papers of increasing MRSA in community was from Hinduja Hospital, Camila Rodriguez and others. So MRSA incidence is increasing. It's about I think, out of gram-positive sepsis, it will be about 30% or so in hospital-acquired infections. So MRSA is becoming a serious problem. Vancomycin resistance is also increasing. Visa, and particularly in Enterococcus, you do see vancomycin resistance. There are limitations of other antibiotics. So this is becoming a more serious problem, yes.
Okay, that's a nice way to start, Mehta sir. Dr. Kapil Jirpe, the need for new options to treat MRSA. We have just heard from Dr. Mehta that almost 30% of the patients, or more than 30%, they can be serious life-threatening with MRSA. So we have got new options to treat MRSA with the background of arbicacin, which is available. How different is arbicacin from the other available of aminoglycosides of tobramycin or with gentamicin or with amikacin? Can you throw some light on this? You are mute, Dr. Jirpe.
As Dr. Mehta rightly said, we always talk about a lot about the MDR gram-negative organism, but one must realize that the MDR gram-positives are rising like a MRSA. Now it is almost from 21, it jumps to the 41%, and they are quite life-threatening. And whatever the conventional antibiotics available like vancomycin or teicoplanin or linezolid, those have a lot of limitations in day-to-day practice. If you look at the arbicacin as an aminoglycoside, it is completely different from the tobramycin and gentamicin. It's a novel aminoglycoside. If you see the spectrum, it's one of the most potent bactericidal aminoglycoside, bactericidal against the MRSA. It works against the biofilm. It has a good penetration against the biofilm. If you see the arbicacin as compared to the tobramycin and gentamicin, arbicacin is quite stable against the aminoglycoside neutralizing enzymes or inhibiting enzymes which are produced by the MRSA. And if you compare against the vancomycin, the post-antibiotic effect of the arbicacin lasts almost 2 to 3 times more than the vancomycin. If you combine all these activity with the user-friendly arbicacin, it definitely scores much more over the existing aminoglycoside as well as the options available for treating the MRSA. And also don't forget your arbicacin activity against the TSS1, that means the toxic shock syndrome toxin 1, which almost 85% it inhibits that enzyme as compared to the 10 to 20% of the vancomycin, and teicoplanin is again 10%. So if you consider the so many advantage of the arbicacin, it's definitely the novel anti-MRSA available in our armament. That's what I would like.
Thank you, Dr. Thank you, Kapil, for throwing light and comparing it with other aminoglycosides and also telling us the importance of the biofilm penetration, mainly responsible with arbicacin. Dr. Sushruta, do you have any Indian data on the efficacy or the time to clinical improvement and the culture negativity with the use of arbicacin in your practice? Have you studied?
There has been studies. Arbicacin has been used. It is not very widely used, but still some people who are using it, they're using it regularly. I think from Kolkata, there was a paper from our neighboring hospital, that was Columbia Asia. There was Dr. Sarkar who came up with a trial of something 25 odd patients treated with arbicacin, various types of resistant organisms, including gram-positive as well as multi-drug resistant gram-negative. And he showed a favorable outcome in many of the patients.
Yeah.
I think that was
There was another phase 3 trial also which came up, and this study was done with MRSA, which had approximately about 162 Indian patients at that minute of time, and they looked after pneumonias or post-operative patients and even deep-seated abscesses. And definitely the overall cure rate, especially when we see as far as the microbiological data and the negativity pattern which was seen after using arbicacin at a dose of 200 milligrams once a day, was approximately, it was good amount of clearance was seen to that subset of patient, and we found that the efficacy in both the groups, if you compare it with 1000 milligrams, 100 milligrams twice a day or 200 milligrams, the efficacy was almost about 97% into the group. So overall, yes, it is a good amount of antibiotic, and definitely it demonstrated a good amount of a fever clearance was seen after the start of arbicacin into the group as compared to the vancomycin group also. Dr. Kushrao Bhajan, can you tell us about the dose and what should be the duration of arbicacin in adult population, and also can you touch upon in short about the pediatric age group? I know you are not a pediatrician, but can you just throw about a little dose on the pediatric aspect?
Thanks, Subal. So it's a very nice discussion that we are having at the moment, and we know that aminoglycosides are notorious for their nephrotoxicity. But arbicacin is a unique aminoglycoside, and the dose for that has been studied, and they have tried in 3 different groups. So less than 5 milligrams per kilogram, 5 to 6 milligrams per kilogram, and then more than 6 milligrams per kilogram. They found the efficacy with these 3 groups to be 77% clinical efficacy in the first group, and then 5 to 6 was 87% clearance, and in the more than 6 was only 89% clearance. So they realized that 5 to 6 milligrams per kilogram is the ideal dose which is recommended. Now there is a little problem here. When we use it, it's been used for 2 decades in Japan and Korea, and their weights are probably much less than the Indian weights. So if you take a 60 kg average, then the dose is 300 milligrams a day. And if you take a 80 kg like me and above, then it would be about 400. So the dose needs to be changed to a 300 milligram vial as well, if that's available. But having said that, what I do is I use about 200 milligrams twice if the person is 60 kg and above for the first 2 days. And then I go every 16 hours instead of every 24 hours to make the right dose happen. If the TDM is available, then there is a trough that is to be kept below 2 and a peak which is to be kept above 15 to 20. One interesting fact, I have used about 30-40 patients, and I have realized that the nephrotoxicity, which is the most worrisome, does not happen till a total dose of 5 grams, which if you calculate takes about 15 to 20 days of therapy, as you asked me for the duration. So if you use it less than 5 grams total, the nephrotoxicity is less than 4%, even though it's an aminoglycoside. But if you use it beyond 5, then it increases to 30%. So I think the duration should be as the patient needs, but it should not exceed a 5-gram dose, which is about 10 to 15 days of therapy.
Okay, thank you, Kushrao, for detailing the dose responses. Let me request Mehta sir to again guide us about whether arbicacin should be used as a monotherapy or it should be used as a combination therapy with other antibiotics depending upon the culture sensitivity report. What has been your clinical experience, sir?
See, there are a few studies. I think there is some paper by Hong. It has been used as monotherapy, but generally arbicacin is used along with some other drug. For instance, for Pseudomonas, arbicacin has been used with aztreonam with a very good synergistic effect. Also, generally, it is used with a carbapenem. That's also a synergistic effect. So that has been used against Acinetobacter, multi-drug resistant Acinetobacter. So the efficacy does increase with that. Not only that, for heterovisa and certain MRSA strains which are sort of intermediate resistance, arbicacin has been used with vancomycin, and that also brings down the MIC and increases the efficacy. So generally, arbicacin is used as a combination therapy, but it has been used for monotherapy also for culture positive patients.
In fact, the antibactericidal effect goes up as a part of synergistic effect in combination
along with these drugs. Yes,
mono effect.
Absolutely.
Thank you, Mehta sir. Kapil, we just heard from Kushrao that how the dose adjustments in renal failure, it should be used judiciously. Can arbicacin, since it's a aminoglycoside, can it be used in renal impaired patients? What should be the doses? And is there any special monitoring do you do in your clinical practice when you're using arbicacin?
Yeah, I agree with the Kushrao regarding the doses and how they compare the 5 versus 6 versus 5 to 6 this thing. And no doubt it is aminoglycoside. At the end of the day, definitely there will be the concern when you are coming across the renal impairment. And unfortunately, in critical care situation, we came across most of times sepsis with multi-organ failure. And one of the indication of arbicacin, whether you use monotherapy or combination, is always in multi-organ failure. So I will say that if suppose you are giving the priming dose, then you can use 75 to 100 milligram. Maintenance dose will be the half the priming dose. And then according to creatine clearance, you can adjust your dose. Like if suppose your creatine clearance in between 20 to 25, just make your dosing 12 to 24 hours interval. Or if just your creatine clearance is dropping less than 20, then you can increase your duration by 24 to 48 hours. But please make a note of that. If initially first 48 hours, I would not like to compromise with my full dose of the arbicacin, irrespective of the this thing. Second thing, if the patient is on CRRT, I will suggest go ahead with the full dose of arbicacin rather than adjusting the dose as per the creatine clearance. So yes, in renal impairment, you have to be used with the cautious. You can adjust the dose. You can select the proper interval on the basis of the creatine clearance, and you can get the maximum benefit of this drug along with the less side effect. That's what I would like to mention about the use of the arbicacin in the renal impairment patients.
Okay, thank you, Kapil. Dr. Shushruth Bandepade, I would like to ask you, arbicacin, it is an aminoglycoside. It is mainly effective against gram-positive organism. Is there any scientific evidence or scientific studies to back this up that way?
I didn't get your question. Yeah, it has been tried on gram-positive organisms.
Yeah, so is there any scientific evidence like arbicacin?
It has got a, yeah. What do you mean is a pharmacological?
Yeah.
No, pharmacologically, yes, it has got a different ring than the aminoglycosides, which it makes it more effective against gram-positives. I have used arbicacin mostly in some typical scenarios. A common indication for arbicacin has been in my patients with SJ and TANE, Stevens-Johnson and toxic epidermal necrolysis. In those patients, we have got a very limited choice of antibiotics, and almost all the patients we get, they come from other hospitals. They already have spent the penem, the safe antibiotics in this scenario, and we need something else for the sepsis actually. Right now, we are also having admitted patients with TANE. There's known an Acinetobacter in the blood, and we are treating her with arbicacin as a single agent. She's not very toxic, not very septic. But then as a single agent, and she has recovered quite well. Come up with the CRP has come down. She's out of fever and febrile right now. So I feel so in MDR organisms, as already pointed out by Dr. Mehta, sometimes you can use it as a combination. But we use combination therapy only right now. Only indication for combination therapy in our hospital is Klebsiella coli. All the other bacteria we usually treat with a single drug as per the culture sensitivity.
Yeah. And do you think it covers?
We don't.
And Shushruta, do you think it covers the gram-negative infections also?
Yeah. As I told you already, we have seen it work well against Acinetobacter, multidrug-resistant Acinetobacter. We have not used it as a single agent in CRE, but we have used it in combination in CRE, combination with colistin. And in spite of 2 nephrotoxic drugs, the renal failure was not disturbed much. Of course, the number is small, but then it has been used in both.
Yeah, and in fact, it has known that arbicacin is almost 2, 4, and 16 times more potent than gentamicin, amikacin, or tobramycin, especially against the ESBL-producing organisms of E. coli, and also against the imipenem-resistant Acinetobacter. Kushrao, can you throw light at, since it's a broad spectrum of aminoglycoside, can you tell us, do you use it empirically in your practice?
So this is probably the most important decision that we clinicians have to make. We know that this is a good drug, which is basically belonging to the aminoglycoside, the gram-negative kind of model, but it has got also gram-positive cover. So if I'm using it empirically, as Dr. Yatin said, it will be a little difficult for me to use it monotherapy. But if I'm using the common ICU principle would be a piptaz or a meropenem along with some sort of a gram-positive cover like Targocid or Vanc or linezolide. So in this scenario, I would probably combine a carbapenem depending upon the situation and the Apache of the patient. I would combine a gram-negative like a beta-lactam inhibitor or a meropenem along with arbicacin. The reason for this would be that I am very sure that it would cover the MRSA. At the same time, it would also have a synergistic activity with the meropenem or the piptaz or the aztreonam. So I would definitely use it as an empirical beforehand, and not in proven cases of MRSA alone. But when I suspect 70-30 gram-negative, gram-positive in my unit, I would be using it empirically, but not monotherapy. I would probably combine it instead of a gram-positive cover like Targocid or linezolide or Vanc.
Yeah, thanks, Kushrao. Since we're on to empirical therapy and we are using it, let us take the experience of using it empirically with the other senior consultants who are with us. Dr. Kapil, what is your experience? Do you use it empirically?
Subal, what's Kushrao say? I agree. Empirically, we always use in a combination, not anytime monotherapy. I have recently 2 patients, and I would like to mention those cases in a short. First case was that was a sepsis with renal failure, already on a dialysis, 2 weeks in my unit, and on the 14th day he developed a fever, tachycardia, hypotension. We sent a blood culture, but we didn't have anything in our hand to start. There was nothing, no organism, gram-positive, gram-negative, both were the possibility. So in such cases, I would prefer to add the arbicacin with the carbapenem or arbicacin with the aztreonam combination, where I can get the good gram-positive and gram-negative since it is hospital acquired. And second case, just 2 days back, transferred to my ICU from the outside, was ischiorectal fossa, operated outside twice and presented with the 53,000 count, procalcitonin of 43, renal failure on noradrenaline and renal failure. Now remember, ischiorectal fossa always have most of times Staph aureus, so it is likely to be MRSA, and might be sometimes you get Pseudomonas also. So my combination were the arbicacin with meropenem with aztreonam to start with, because I don't know whether next 48 hours is going to give me for just saving his life. So in empirical, I will say yes, it is one of the drug of choice when you are not sure gram-positive, gram-negative. It has a good gram-negative coverage, like it can cover your Acinetobacter, Klebsiella, as well as the Pseudomonas. but always with the combination with the either carbapenem or astronam. That's what I would like to mention on the background of the empirical therapy.
Okay, thank you, Kapil. I would like to go to Mehta sir for two back-to-back questions. First, Mehta sir, can you tell us about your empirical use of arbicacin into your practice? How do you use empirically?
No, again, I would agree with Kapil. What he said that when you, first of all, when you're not sure what the source of infection or what the bugs are, then I would use arbicacin along with the gram-negative additional cover. Carbapenem would be the commonest one to use. See, arbicacin will take care of MRSA, and it will give some cover for gram-negative sepsis. But you'll need additional antibiotics for that, unless it is culture-driven. So generally, it will be a combination which I would use empirically in my ICU.
Which combination would you prefer? Is either with Mero or is it with imipenem?
Yeah, see, there is nothing much to choose between Mero and imipenem. So either one of the two, along with arbicacin. Yeah.
Okay. The second question to you, Mehta sir, is like, in this pandemic, have you used it in secondary infections in the post-COVID ICUs? Post-COVID secondary infections?
I don't have a problem in using it, but so far I have not used it in, because probably we didn't have the culture sensitivity for that. And empirically, generally, we give teicoplanin along with the carbapenem to start with in these sort of sicker patients. But yes, it would give a broader cover, so it does make sense to use it along with the carbapenem or along with the colistin or poly-B, whatever you use.
Okay. And Shushruta, do you use it into COVID ICUs where to avoid secondary infections?
To avoid or to treat, yes, I've used.
To treat, avoid, sorry, the question.
Not widely, but then we have used it. Main thing is that we have right now got reservations against vancomycin and teicoplanin both. They have been our basic weapons against MRSA, but right now we feel that they do not penetrate the lung very well. Vancomycin definitely doesn't, teicoplanin perhaps does. Teicoplanin problem is too much of protein-bound drug, and actually for serious infection, the recommended dose is 12 grams per kg, which is a very high dose, and 12 milligrams per kg. That is the very high dose, and that we don't use it here. We use it a much lesser dosage. The American literature does not say much about teicoplanin, so we get it from other sources. So for that matter, I feel that arbicacin can fill in the gap, that it can be an antibiotic which will cover the MRSA with a very specified dose, and it can penetrate the lung better than both of this vancomycin and teicoplanin. So we have used it, not very widely, but we have used it in COVID ICUs too. Yeah.
Yeah. Kushra, your thoughts on the use in COVID ICUs? Yes, Kushra, it's up to you.
So
Over to you.
basically, I don't think we should differentiate a COVID or a non-COVID ICU. The bacteriology is more or less the same. It is proven. In the first week, we would probably get the sensitive bugs. And in the second week onwards, we would get the resistant bugs, whether it is MRSA or whether it is CRE. So we need to base our decision on COVID scenario as importantly as a non-COVID scenario. One important point which Shushruta brought out is about the lungs, and it has been proven where arbicacin has a very good penetration into the lung fluid and bronchoalveolar fluid, and therefore it can even be probably tried like tobramycin as a local installation nebulization. Secondly, they would just take you to one study where they did the MICs of arbicacin with all the other antibiotics for the bugs, and leave alone MRSA, but for E. coli, Klebsiella, and even for Pseudomonas, they had an MIC of 1 to 2, whereas for Acinetobacter, it was more than 128. So probably it does not work very well in the Acinetobacter scenario, but if you are suspecting E. coli, Pseudomonas, and Klebsiella, the MICs are low for arbicacin, and therefore it can be added even in the COVID scenario.
Yeah, thank you, Kushra. Kapil, one question for you is, and if just anybody can comment after Kapil, like we know that we are dealing with a drug-resistant MDR, especially in gram-positive infections. So do you think that we have found arbicacin as the magic bullet for it?
Answer is yes. See, we need to say that rather than magic bullet, if we use it judiciously in a very selective patient, Yes, it is one of the good choice in a current option. If you see what are the choices, like everybody is talking about the vancomycin, teicoplanin, daptomycin, linezolid. I told you already, arbicacin has that potential to have a safety profile, more safety profile, most effective as a sidal, biofilm penetrating, and a single dose. That is one of the easy to give. Doesn't need any monitoring or infusion. Considering all these advantage with the arbicacin, I definitely say it may be proven to be magic bullet in future, provided we use it in a right indication and in the right doses in the right patient, and try to make the right combinations. That is more important when you are treating it as a empirical. It should not be the again. We should not. It should not be the victim of the abuse and misuse in future. That's what I would like to say about the arbic acid. Thank you.
Yeah. Mehta sir, your comments, quick comments about is arbicacin the magic bullet we have found out?
No, unfortunately, there is no magic bullet in medicine. So there is no magic bullet, but yes, it's a new antibiotic. The Indian MRSA have not, recognized arbicacin as such. So I think it is likely to be more effective, at least for the next few years, against MRSA. And having gram-negative cover does help us because we get a broader cover along with some other antibiotics. One thing we need to point it out is sensitivity risk, and second, also availability of therapeutic drug monitoring. It has been recommended by most of the authors and papers on this. So I would request ALChem to facilitate availability of TDM and sensitivity testing in other places so that you can use it more extensively. It's a good drug with sensible use. Don't use it for every patient who comes in.
Absolutely. Kushra, one quick comment, passing comment about magic bullet.
So I kind of am right in between Kapil and Dr. Yatin. So I agree.
I'll squeeze you in.
Yeah, I completely agree that it is a very, very promising antibiotic, and it is underused, unfortunately, even though it's available to us in India since the last 2 years. I think only the panelists and a few others are using it. I feel it's the ignorance of knowing how good the drug is and how safe the drug is, because they say, oh, aminoglycoside, no, we won't use it, is the main problem. So it's a very promising drug, as both the panelists have said, but I agree completely that there is no magic bullet in our ICU scenario. But it may become later.
Yeah. So Shushruth, your comment on the magic bullet.
Again, the thing is, I don't believe in this term magic bullet. There's nothing called a magic bullet. There cannot be one single antibiotic which will cure all. Their antibiotics will develop resistance. There would be scenarios where it would be preferred, and there will be scenarios where it is not preferred. As already pointed out by Dr. Mehta, we need tissue drug monitoring. That's very important. And we should also have this flexibility of packaging, 200 milligram, 300 milligram. I always use 300 milligram taking as a 60 kg body weight. That is what we do. So we need to find out typical niche patients where we feel that there might be positive, gram-positive resistant bugs or possibility of not very resistant, but MDR bugs. So that is the area where arbicacin is good in as a single drug or in combination. That is the position of arbicacin right now.
Thank you, Shushruta. So thank you all the panelists. So the take-home message, what is there for all of us today and the audience is, yes, arbicacin is a very stable aminoglycoside which is inactivating the enzymes which are produced by MRSA. It should be used, and best results are seen if used in combination with a carbapenem if compared to a monotherapy. It is a bactericidal effect of arbicacin is much more important in MRSA, and more importantly, it has got a very excellent biofilm penetration, and it is much more potent than other forms of aminoglycosides like tobramycin or amikacin or gentamicin. So thank you very much. Thank you, Dr. Yatin Mehta, Dr. Kapil Jirpe, Dr. Kushra Bhajan, and Dr. Shushruta Bandopadhyay. I also thank for all the audiences who have joined in to listen to this panel discussion. And in the end, again, I would like to thank ALChem Pharmaceuticals for their generous support for this Criticare 2021, which is being held virtually. Thank you all and stay safe. Thank you very much.
Thank you, Subal.
Thank you.
Thank you, Dr. Subal Dixit and esteemed panelists for that wonderful, excellent presentation. We have come to a, can I have a video on, please? So we have come to a conclusion of the sessions, and the last session, which was supposed to be scheduled here, the thematic session, case-based discussion on geriatric infection by Dr. Pradeep Bhattacharya, will be now on in the hall Susrita. So I request all of you to log in there for that. And now I actually thank all the audience who participated here and all the panelists, all the speakers and all the chairpersons. And I thank all the participants for the same. And we will have a small video presentation for the same. Can I have the video presentations on, please?
Somebody please help! क्या हो रहा है? क्या हुआ? Please help! Someone please!
Okay, ma'am. मैंने अभी CPR सीखा है. I think I'll be able to help. Okay, just let me try. I'll do something. Okay. Okay, don't worry. Okay, I'll do something. Okay. Step 1, tap shoulder and shout. Hello? 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 Are you awake? Hello? Step 2, check breathing. Step 3, call for help. Call 108 now. Step 4, CAB. See, compression, 100 per minute. Hands between the nipples. On the bone, place the palm on top of the other. Lock, arms straight and go. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. Come on. 1, 2, 3, 4, 5, 6, 11, 12, 13, 14, 15, 27, 28, 29, 30. Don't give up. All right. All right. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25. 25. He's breathing. He's breathing. He's breathing. Okay. Yes. He's breathing. Okay.
Yeah, thank you for all the participants, and we conclude the session. Thank you all.
you